Yes. Am I
Yes.
audible?
Yeah, you are audible, sir. I
Good
think
morning, sir.
we can start, sir.
So it's 3, 2, 1. Now we are allowed to the attendance. Over to you, sir. You can start the session.
Good morning. Good morning from FOGSI ICOG PG Clinic Program. We are here again on second Sunday of the month. Not second Sunday. Last Sunday we were busy with our managing committee meeting of FOGSI at Gurugram, and so we have planned this month PG Clinic on third Sunday. And we welcome you all, our dear faculty members, our students, and before I start and I talk you about the program and everything, I have with me our chairperson, FOGSI, ICOG chairperson, Dr. Parag Biniwale, and at the outset, we would like to thank our FOGSI president, Dr. Sunita Tendulkarkar, and chairperson, ICOG Parag Biniwala, sir, for allowing us to continue with this opportunity to run the program in the third year onwards also. And without any wastage of time, I invite Dr. Parag Biniwala, sir, to say a few words.
Thank you, Ashok. Good morning, all. I bring greetings from ICOG, and it's indeed a pleasure to address the PG Clinic yet again with a new episode of PG Clinic. I must appreciate the efforts put in by Dr. Ashok Kumar, the Vice Chairperson of ICOG, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur Rahman, who have persistently carried the baton of this program for last 3 years plus, and this is one of the flagship programs of ICOG, which is so popular among students. I must thank all the faculty who've agreed to join today. Dr. Madhavi Gupta from Delhi. Special thank you to Dr. Shanta Vibala from the Government Medical College Delhi for preparing the students and of course the examiners. Dr. Arup Kumar Maji is here, Dr. Hemangi, Dr. Shivli Chanda Chakravarti, Dr. Jyotinath Modi, and of course our own Dr. Ashish Kumar Mukhopadhyay. I'm also looking forward to an interesting session by young dynamic Dr. Subhash Malya, who's the past chairperson of FOGSI Endoscopy Committee, who will be deliberating on diagnostic hysteroscopy. And of course, the add-on this year is the quiz led by Dr. Archana Kumari, chairperson of FOGSI Quiz Committee. So I'm looking forward to one very, very interesting session today because hyperglycemia is one of my favorite topics too. It is one of the biggest challenges that we obstetricians are facing now, and it is going to increase more and more. So I look forward to a great learning session. I'm wishing all the best to the students and happy learning to everyone. Thank you.
So thank you, Dr. Parag, sir. Welcome to all faculty and students and all our participants. So today our program is very interesting, and as you know, we have 3 sections in the program of PG, and lastly we have the quiz. So we have our Master the Dummy session, and today we will be talking on uh, clinical assessment of pelvis and diagnosis of disproportion by Dr. Madhvi M. Gupta. She is the director professor and unit head at Maulana Azad Medical College. And then we have a case discussion on hyperglycemia or diabetes in pregnancy by students from Theni Medical College, Theni, Tamil Nadu. And they are ably guided by professor and head of GTMCH Theni, Tamil Nadu Medical College, and by Dr. Shanta Vibala. And we have our expert as usual, Dr. Ashish Mukhopadhyay, Dr. Jyotinath Modi, she is professor at Bhopal, AIMS, and Dr. Arup Kumar Maji, everyone knows him. He is professor at Santi Niketan Medical College, West Bengal. Then we have Dr. Hemangi Chaudhary, professor of State Medical College and KEM Mumbai, and Dr. Shuli Chanda Chakrabarti, associate professor from Calcutta. So with all these expert teachers, I hope our session will be very exciting and very knowledgeable and will give lots of information to our students. And then our last session of the program is on master the technique, which we want to give them the skill-based learning to all the students. And in this, we will teach them how to do the diagnostic hysteroscopy. And none other than Dr. Subhash Malya. He is a senior consultant from Calicut, and he has been a regular teacher with us, and he has shown the teaching in earlier program also. Then in the last, we will have our quiz program on hyperglycemia, and our dear chairperson of FOGSI quiz committee, Dr. Archana Kumari, will be conducting the quiz. And quiz is another indirect means of learning, and you are excited to know new things in the quiz program. And I also would like to remind all of you that all these recordings, the programs recording of today's program as well as previous programs, are available on ICOG website, and you can take the advantage and by visiting the website and learn about the previous topic which we have covered earlier also. And I would also like to thank my co-coordinators, Dr. Ashish Mukhopadhyay and Dr. Hafiz Urban. Without their efforts, I think this program will not be able to sustain itself for last 3 years. And now I again, once again, would like to express my sincere gratitude to FOGSI President, Dr. Sunita Tendulkar, and FOGSI Chairperson, Dr. Parag Biniwala. Then we have FOGSI Chair-elect, Dr. Sheila Mane, and our Secretary, Dr. Sarita Bhalerao. This team is doing a good work, and under their able guidance, we are able to run this program. So I would now request Dr. Ashish Kumar Mukhopadhyay, sir. Dr. Ashish is there?
Yes, I am there.
Yes. So I request you to share your views, and then we will start the program with Dr. Hafizur Rahman.
Yeah, I am also in the midst of another ICOG session here at Kolkata in the VP conference, East VP conference. So I'm I have just came out of that hall. But as you know, ICOG is marching ahead. 3.5 years, we are continuing this program of PG Clinic. Second Sunday of every month, we assemble, and we are always thinking about new ways or innovative ways to, attract the attention of the students as well as making it useful for them, taking care of the NMC guidelines. So I think we very recently we have added quiz program to this just to make it more interesting, and knowledge is limitless in PG system. So we are completely aware of that. So you start with the very basic things like dummy fetus pelvis, then you go into case discussion, and then you go into the practicing all those things, and lastly the quiz. So I think that it is becoming more and more popular among the students, and I hope to add new things as time emerges with the kind contribution from Professor Ashok Kumar and also Professor Hafizur Rahman. And Dr. Sheila Mane is also there to put her inputs. I think it is going to become more attractive in future. But whatever happens, don't forget to log into the ICOG website, because everything is available at the website. Thank you very much. And I hope this will be beneficial for the students. Thank you so much.
Thank you, Dr. Ashish, sir. Thank you very much for sparing your valuable time. You are busy with this conference. I know that. So I would also like to remind our viewers that the recording is available on the ICOG website. This you should take care of. And I also would also remind you that we are making all efforts that we involve students as well as teachers from the different parts of the country. And we are reaching all the remote areas as well as the unknown areas of India where our students are there. And today, as you can see, the students from Theni are with us, and the teachers also from Theni with us. And let me tell you one more thing. I take this opportunity to inform you also that on 2nd of May onward, from 2 p.m. onward, the announcement will be there very soon. And Dr. Parag Biniwala is here. Sir, I am informing them about the program, and you can throw some light also on that. We are starting a program for teachers, Odyssey of teachers, where we would like to learn about the different teaching learning methods. And this will be an online program for teachers who are interested in learning teaching methods for the students, for other candidates. And this is open to all, free of cost, and anybody can take part in this. And this will be, first program will be on 2nd May from 2 p.m. onwards, 2 to 4:30. And Dr. Parag, sir, would you like to say something on that?
Yeah, so this is our attempt to reach out to all the medical college professors. All of us are aware about the new teaching methodologies that the NMC has introduced, and Dr. Ashok came with a proposal that we should update all our professors, especially in smaller places where they may not have an access or they may not be able to update themselves in this. So this is our attempt to reach out to them with and Dr. Ashok and our entire team is taking a lot of efforts to demonstrate various teaching methodologies. So do log in. Those of you who are senior people sitting here who are interested in being part as a faculty, please get in touch with Dr. Ashok, and we will certainly use your expertise to disseminate more knowledge about this.
Thank you, sir. So now I hand over to Dr. Hafizur Rahman to run the program. Thank you, Dr. Hafizur.
Good morning, everyone. Thank you so much, Ashok sir. So as we are always thankful to FOGSI President and office bearers and ICOG Chairperson Dr. Parag Biniola sir, and all my team, Dr. Ashok sir and Dr. Ashish Mukhopadhyay sir. So we'll go by session. So I'll not waste much time now. We are going to start with our session 1. That has been always a consistent session for upgradation as skill enhancements for postgraduate student. So it is on fetal skull and maternal pelvis. So today's session will be on clinical assessment of pelvis and diagnosis of disproportion. Now, this session will be taken by Professor Dr. Madhavi Gupta, madam. Madam is Director Professor at Maulana Azad Medical College, New Delhi. So after that, we'll have on the case discussion. So I'd like to request you now session to hand over to Madhavi, madam. Madam, if you can share your screen and have the demonstration as well as over to you, madam.
Okay, thank you. At the outset, I would like to thank Dr. Ashok and Dr. Hafizur Rahman for this opportunity. And I'll start sharing my screen. Okay. So the topic is maternal pelvis, fetal skull, and assessment of pelvis. Right from the beginning, the moment we in MBBS, when we start going for clinical postings in phase 2, phase 3, part 1 and 2, we are taught pelvis and fetal skull. Because of the importance that we, even as postgraduates, we need to know, because if we are thorough with the pelvis and the anatomy of the skull, labor management is easier, be it normal or abnormal. So maternal pelvis is made up of 2 bones, as we know, the 2 hip bones, and which in turn are made of 3 bones each. And these 2 bones together form the pelvis. And the pelvis is the false pelvis, which is above the, basically formed by the iliac crest, and the true pelvis. The obstetrics part basically concerns with the true pelvis, because this is the part of the pelvis which provides the passage to the passenger, the fetus. So the true pelvis has an inlet, a cavity, and an outlet. Okay, so this inlet is actually a plane, and it's not horizontal also, and it makes an angle of roughly around 55 degrees with the horizontal. And it is so because of the articulation of the 2 femoral heads with the hip bones. And because of that, this pelvis is at an angle of 55 degrees. And this inlet has a boundary on each side, the symphysis pubis. Then there is the pubic crest, pubic tubercle, then the pectineal line, iliopubic eminence, iliopectineal line, then sacroiliac joint, anterior border of the ala of the sacrum, and the sacral promontory. Okay, this pelvis has diameters, planes, and so it's actually a plane. So diameters are a transverse diameter, which is the distance between the 2 furthest points. Then there is the AP diameter, which are actually 3 AP diameters. We call them the conjugates, true conjugate, the obstetric conjugate, and the diagonal conjugate. And another is the oblique diameter. Before I go on to the conjugates, the oblique diameter is actually from the sacroiliac joint to the iliopubic eminence. So the nomenclature is left oblique diameter is in you give the nomenclature left and right when you keep the sacroiliac joint as the left or right. Okay. So then coming to the conjugates. The most important conjugate is the obstetric conjugate, and the true obstetric and the diagonal conjugate. The true conjugate actually extends from the upper border of the symphysis pubis to the sacral promontory. The diagonal extends from the lower border of the symphysis pubis to the sacral promontory. And the obstetrical conjugate, which is the most important and which cannot be assessed clinically, extends from the slight projection on the posterior surface of the symphysis to the sacral promontory. So although it is most important and we still cannot measure it clinically, how do we do it then? So we measure the diagonal conjugate by putting our 2 fingers inside the vagina and trying and touching the sacral promontory. So most, if you have long fingers, you may be able to touch, but that doesn't mean. And you have to deduct 1.5 centimeters. Everybody should actually have an idea what is the length of their fingers, the tip of the middle finger to where the thumb joins the palm and a little in front. And then you deduct 1.5, because you cannot take a scale and measure then. You have to have an idea beforehand, because this is the normally true conjugate is 11. Obstetric is 10.5 after deducting 1.5 from the diagonal conjugate, and then diagonal conjugate is 12. So this is how we will measure. So what all do we have to consider when we talk is, so that is the plane we've already talked. Then there is the inclination, the axis, and the diameters. We've talked of the axis also. The diameters. Now axis, I'll talk a little bit here and then later on. So axis is a line which is passing 90 degrees to the plane. So when you extend this axis, it will pass through the tip of the coccyx for the inlet. So after the inlet, we come to the pelvis. The maternal pelvis is a cavity, the cavity of the pelvis, which is bounded above by the plane of the inlet and below by the plane of the least pelvic dimensions. So the anterior wall is 1.5 inches, the posterior wall is 4.5 inches, and the lateral wall is 3 inches. So it's easy to remember 1.5, you keep adding from anterior, 1.5, 1.5, 1.5. And it is also the plane of greatest pelvic dimensions, and all diameters are 12 centimeters. Okay. So the significance of this is that when the head, the leading point hits the pelvic floor, it undergoes internal rotation. The maximum diameter of the head is in the plane of greatest pelvic dimension. So it gives good space for the head to rotate. So below the cavity comes the narrow pelvic plane, or the plane of least pelvic dimensions. So if the shape is anteroposteriorly oval, and it is bounded, the plane starts from the lower surface of the symphysis to S5. And the cavity, the plane of the cavity, which I forgot, so which is the plane of greatest pelvic dimension, starts from the posterior surface of the middle of the symphysis, where that slight projection is, to junction of S2 and 3. This is the plane of which has the maximum diameters, a circular plane, 12 centimeters. Okay. Then below the plane of greatest pelvic dimensions is the plane of least pelvic dimensions, which starts from the lower surface of the symphysis pubis there to the S5. The laterally it is bounded by the 2 ischial spines. So these are the 2 ischial spines. Okay, the 2 ischial spines. So, and because the distance between the 2 ischial spines is only around 10.5 centimeters, this is the smallest diameter of any part of the pelvis. So what we saw in the cavity, it is a transversely oval shape. Then inside this pelvis, the cavity of the pelvis is circular, 12 centimeter all diameters. Then we are coming to the least plane of least pelvic dimensions. And this plane of least pelvic dimensions is also part of the outlets. Okay. So the significance of the ischial spines here is the narrowest plane of the pelvis. Here the levator ani originate. Internal rotation occurs here because the shape of the levator ani is like a hammer, down and in. So the moment the leading part hits the pelvic floor, the levator ani, it will rotate and the head will flex. The zero station is also at ischial spines. Above the ischial spines, it is plus and minus, and below the ischial spines it is plus. There is a change in the direction of the axis, and the pudendal nerve block is also given here. So now we are talking of the outlet. There are two outlets, the obstetrical outlet and the anatomical outlet. The obstetrical outlet is actually a segment, and the anatomical outlet is a plane. So the obstetrical outlet starts from the lower border of the symphysis to S5, okay, and the ischial spines, okay. This is also the plane of the least pelvic dimensions, and below this obstetrical outlet, so this is the shaded yellow portion is the obstetrical outlet. Below is the anatomical outlet, which starts from the lower surface of the symphysis to the tip of the coccyx. This is a plane and this is a segment. So this, and both of them have a deficient anterior wall. So below the obstetrical outlet comes the anatomical outlet, which is only a plane. So here this shows an inferior view of the pelvis. So this is the symphysis pubis. This is the tip of the coccyx. So this will be the AP diameter of the outlet. And this is normally around 9.5 to 11.5 centimeters. And during labor, this will push. So this maximum is when the this coccyx is pushed around 2.5 centimeters by the fetal head. Okay. So the shape of the anatomical outlet is like a lozenge, a diamond-shaped cavity, which is antero-posteriorly oval. There are two triangular planes with a common base formed by a line passing through the two ischial tuberosities, okay, and two apices, one just below the pubic symphysis, another at the tip of the coccyx. So now we just see this is the brim, which is transversely oval, the cavity, which is circular, then the outlet, which is lozenge-shaped or a diamond-shaped structure. Here, the maximum diameter is the transverse diameter. In the cavity, all the diameters are the same. And in the outlet, the AP diameter is the maximum. So this has a significance in the mechanism of labor. Yeah. So the head enters the cavity in the transverse diameter. Nearly 70 to 80% of the cases, the head will enter in a transverse diameter. Again, the head gets the biggest diameter to enter because it's a transversely oval cavity. Then, as I said, in the plane of greatest pelvic dimensions in the cavity, the moment the leading point hits the pelvic floor, the largest diameter of head is in the plane of greatest pelvic dimensions. But because it is a circular cavity, all the diameters are equal and the head will come to the oblique position. Now coming to the outlet, it is a transversely oval, AP oval, and this is the largest diameter, and the head comes in the AP diameter. The sagittal suture comes here, so that the head of this occupies the biggest diameter, and this facilitates a smooth labor. So now we see that the pelvis has 4 planes. Okay, this is the inlet. This is the plane of greatest pelvic. The number 1 is the inlet. Number 2, excuse me. Number 2 is the plane of greatest pelvic dimensions from the middle of the posterior surface of symphysis to S23. Then the plane of least pelvic dimensions from the lower border of the symphysis pubis to S5. Then this is the anatomical outlet, which is also a plane from the lower border of the symphysis to the tip of the coccyx. These are the 4 planes, and there are 2 segments. The 2 segments are, one is the gray one, this is the cavity of the pelvis, and this yellow one, this is the obstetrical outlet. Okay. So as I said, because they share the same, the anatomical and the obstetrical outlet, they share the same anterior point. It is the anterior wall is deficient. So another important thing when we talk of the outlet is the subpubic angle. This is the angle formed by the 2 pubic rami. Okay. So how do you assess? You actually assess by keeping your 2 fingers. Normally it should be 90 degrees plus minus 5 degrees. Because if it is a narrow angle, there will be a problem. This space, the head, when it comes here in the outlet, it will occupy. If it is a broad angle, distance between the angle apex and the circumference of the head will be less. So bigger diameters, this diameter will be bigger. The AP diameter of the outlet will be bigger, the blue one. But if this angle is narrow, the head will be pushed posteriorly and smaller diameter of AP diameter will be available for delivery. So consequently, what happens is the head will be pushed posteriorly and there are chances of perineal injuries. So okay. So another thing about the anatomical outlet was that we talked about the anteriorly, it is a lower border of the symphysis pubis, posteriorly the tip of the coccyx, but laterally it has the ischiopubic rami, ischial tuberosities, and the sacrotuberous ligaments. Okay. So then we come to the, but another thing is this is again not a horizontal or a straight plane. It is slightly at an angle of 10 degrees. Okay, because our pelvis is inclined at an angle of 55 degrees. This plane of the anatomical outlet makes an angle of 10 degrees. Now we come to the axis of the pelvis. So planes, we have talked 4 planes, and the plane of the inlet, plane of the cavity, and plane of the outlet. Axis is always a line, an imaginary line which passes at 90 degrees to any plane. So this one is CD is the axis of the inlet. So we said inlet is from the upper border of the symphysis to the sacral promontory. So when this line is passed, extended upwards and downwards, it will pass through the tip of the coccyx and other through the umbilicus. Okay. Then this is the outlet, which is the lower border of the symphysis to the S5. This is the obstetrical outlet. Okay. Another line which passes through is, you extend it upward, it will pass through the sacral promontory. Okay. So if you join these lines, similarly, there would be another line 90 degrees to the plane of the cavity. And when you join these lines, it will form a curve like this. Okay. So this is called the curve of Keras. So this axis of the inlet, axis of the cavity, and axis of the outlet. So this is called the curve of Keras. So this is the obstetrical pelvic axis, and which is directed downwards and back and then directed forwards. So we should know the axis of the pelvis, because this would be the, especially the outlet, because this would be the direction of pull in case of operative vaginal deliveries. So I think the pelvis is done. I'll come to fetal skull. And in the end, I will talk of how to assess the pelvis. Okay. So this is the fetal skull. We all know fetal skull has 2 fontanelles, sutures which we are aware of, and areas. So fontanelles are the anterior fontanelle and the posterior fontanelle. We should always know that the anterior fontanelle has 4 sutures merging here, and the posterior fontanelle has 3 sutures, because in labor, it will not be very easy to identify the shape of any fontanelle. It is always easier to make out the number of sutures. And then there are the different sutures, the sagittal suture, then there is the coronal suture, frontal suture, and the lambdoid suture. Okay. And what is the most important part? We know there are areas, but I will talk only of the vertex. Vertex is a quadrangular area which is bounded anteriorly by the coronal suture, posteriorly by the lambdoid suture, and laterally by 2 lines which are imaginary lines passing through the 2 parietal eminences. So this is the vertex. So knowing the anatomy of the fetal head helps us in finding out during labor the attitude and the position of the fetal head. Attitude means the attitude of flexion, deflection, extension, partial or full. Okay, because that has an implication in normal labor or abnormal also. Okay. So these are the fetal skull. We know all the diameters of the fetal skull. We would mostly in a fully flexed head, a normal labor, if we talk, fully flexed head, what would be the diameter would be suboccipito-bregmatic from below the occiput to the center of the bregma. You know, one thing we should remember that the dimension of the bregma is 3 into 3 centimeters. So don't say anywhere on the bregma because it can make a difference of 3 centimeters or 1.5. So it is the center of the bregma. Okay. This is in a fully flexed head. This is the AP diameter of engagement in a fully flexed head. The transverse diameter of engagement will be the biparietal diameter, and there are different diameters depending on to the degree of flexion. So in a fully extended head, which is a face presentation, the diameter would again be 9.5 centimeters as a fully flexed head, which will extend from the root of from where the base of the mouth and the chin to the center of the bregma. This is again 9.5. And as the degree of extension decreases or flexion decreases, the diameters increase and they become either suboccipitofrontal, occipitofrontal, and then submentovertical and mentovertical, where it is the brow presentation and there is no mechanism of labor in brow. Submentobregmatic, it is the face presentation where this part you can feel during vaginal examination. Okay. So these are the different diameters which I just said, and what is the attitude of the head, which is a completely flexed vertex or a completely extended face. The diameters are similar here. And as the degree I said flexion decreases or extension also decreases, it becomes bigger diameters. And in brow, when it is partially extended, it's the biggest diameter and no mechanism of labor. Okay, so attitude of the head as attitude and position of the head. Position means when you, attitude is degree of flexion or extension, and that will determine what is the presenting part, vertex, face, brow, and position means the relationship of the part to a fixed bony point to a one of the quadrants of the pelvis. So this is a fully flexed head. The attitude of the head is fully flexed. So see, the diameter is only 9.5 centimeter. Here again, as the flexion decreases, it will become bigger. And this is brow, and this is again a face presentation where it's a fully extended head. So this is how the shape of the head into the pelvis will set. So now we talk of the fetal skull transverse diameters. So biparietal we know in a fully flexed head, then bitemporal, bimastoid. Then we come to the super subparietal. What is the significance of the super subparietal diameter? It extends from slightly above the parietal eminence of one side to slightly below the parietal eminence. It is slightly smaller than the biparietal diameter. The significance comes when there is asynclitism. You know, asynclitism is when there is a minor degree of disproportion. To explain it simply, suppose there is a narrow passage. We are going straight, but we cannot go straight. So if we tilt slightly like this, we are able to pass. So that is how the head negotiates a slight minor degree of narrow passage through this asynclitism. That means this sagittal suture is not in the transverse diameter. It is either a little towards the symphysis or away or towards the sacral promontory. There can be, and one of the parietal bones will be the leading parietal bone. So anterior asynclitism is when the anterior parietal bone is the leading bone, and the sagittal suture is towards the symphysis. It happens more in multipara because the tone of the abdominal muscles is poor. Okay, and similarly in primiparas, the posterior parietal bone is the leading bone. The sagittal suture is slightly towards the symphysis. So this is anterior asynclitism. So another thing is molding, which is what we talk of molding is that as I said, there are sutures. Normally the sutures are separated during intrauterine life. And the site is, the molding is parietal occipital or parietal or parietal frontal. So to assess molding, you have to just see when there is just closing of the suture line, it is +1. That is just overlap, which is reducible when you do it manually, it is +2. But when the molding becomes irreducible, that means it is pathological and you need to deliver the baby by cesarean section. Okay, now we come to assessing the pelvis and see. Okay, what are the different parts? Pelvic assessment is actually you assess the inlet, you assess the mid cavity, and you assess the outlet. Okay. So they are usually done after 37 completed weeks. Patient should be dorsal position, hips flexed and slightly abducted. Knees are flexed, buttocks at the edge of the table, empty bladder, and asepsis has to be maintained. Please explain to the patient what you are doing and respect her privacy and maintain her dignity. Okay. So inlet, at every place, it's easier to remember when you see that every place you have to assess three things. Okay. So in the inlet, you will assess the diagonal conjugate for obstetric conjugate. Okay, you cannot assess the obstetric conjugates, you will assess the diagonal conjugate. So you will assess the posterior surface of the symphysis pubis, and then you will assess the pelvic bridge. Okay, palpate it. Then mid pelvis, again the curve of the sacrum you have to assess. Then the lateral walls you have to assess whether they are parallel, divergent, convergent, the ischial spines. This will give you an idea about the interischial diameters. Okay, and the sacrosciatic notches, which should normally accommodate 2 fingers easily. If they are not accommodated, then it is not. You cannot assess oblique diameters in the mid pelvis and all because of the soft tissues. They obliterate these areas, so oblique diameters cannot be assessed. Then you come to the outlet. You assess the subpubic angle by 2 fingers, as I just said, how you will assess with the 2 fingers, keeping onto 2 ischiopubic rami. Then you will assess the mobility of the coccyx, the AP diameter of the outlet from the lower surface of the symphysis to the tip of the coccyx, and then just a minute. And the transverse diameter of the outlet will be assessed through keeping your knuckles in between the 2 ischial tuberosities. Okay, so this will give you an idea about the outlet. Okay, and this is our outlet tip of the coccyx to the lower diameter of the lower surface of the lower surface of symphysis. Okay. So yes, now coming to this pelvic assessment of cephalopelvic disproportion. There are 2 methods. This is the abdominal and vaginal method. Another is also only an abdominal method. So here what you do is you introduce 2 fingers into the vagina, and your left hand is holding the fetal head. Okay, so you will gently push the head down and back. If it goes easily without touching without coming over your fingers, your thumb is on the symphysis without touching your thumb, then it is fine, the bring. Okay, but if it slightly brushes against your thumb, then there can be some minor degree. But if there is a significant overlap, then there is disproportion. Another important thing to remember is you can give a trial when there is disproportion at the level of the brim, because it is fairly early in labor that if the head does not enter the pelvis. There are different reasons for the head not entering the pelvis. We are just talking of cephalopelvic disproportion. You're still early in labor, not the morbidity of be it surgical or patients. Labor has not progressed so much so that it will affect. So you can give a trial. If it doesn't go into the pelvis, you go ahead and do a cesarean section. But if you have a doubt in the mid pelvis or the outlet, there is no role of trial. Okay, because mid pelvis and outlet, normally outlet contractions are associated with mid pelvis contractions. Isolated outlet contraction is a very rare occurrence. Okay. And another method is where you don't do a PV, you just put your use the left hand to push the head and put your 2 fingers here on the symphysis pubis, and rest is the same. If it doesn't touch your fingers, goes easily in the pelvic cavity, there is no disproportion. But if slightly brushes your fingers, then there may be some minor degree. But if it just overrides your fingers, then there is a disproportion. Okay. I think that is all. I would be happy to take any questions.
Thank you, ma'am, so much. I think we can have the questions a little bit of later. If any question is there, we'll ask you, ma'am. But as of now, we don't have any question.
Okay. Thank you.
Thank you, ma'am. Thank you, ma'am, so much for your excellent demonstration. And I am sure this is going to be much helpful for the students, and the program will be in the recording also. So this will be very much helpful for the students, those who will be watching later on also. Thank you so much, ma'am.
Thank you.
So we'll move to our next session, that is on our session 2. Sir, Ashish sir, you would like to say anything? Madhavi madam has concluded.
Yeah, it's an excellent demonstration of the pelvis, the assessment of cephalopetal disproportion, and also there was detailed discussion on the fetal head. A very impressive discussion, and I believe that the students, if anybody has missed it, will go to the website and go through the recording. This will serve as a important lesson which is stored in their memory. There are many ways that we can discuss, demonstrate the pelvis, mechanism of labor, etc. So we are exploring all possible ways how to, deal with the pelvis and fetal skull, because that is a major part of their examination. And a good number of marks is attributed to this thing. We are thankful to Madam for excellent demonstration. And let us proceed to the case presentation now.
Thank you, sir.
Yeah, thank you so much, ma'am. So now we'll move to our next session, that is the case discussion, and it is one of the most anticipated session. So here the students.
शुरू करो.
So now this session will have the students from the government Theni Medical College. They will present the case. So the case is on diabetes in pregnancy. Dr. Shruti and Dr. Janupriya BM, both are third-year postgraduate student, and they have been guided by their coordinator faculty, that is Professor and head, Dr. Santa Vivala Madam. So we would like to thank you them initially for their participation for this. I am sure this is going to give them lots of opportunity. Now we have faculties like galaxy of faculties. Dr. Ashish Kumar Mukhopadhyay, sir is principal professor at CSS College of OBGYN and Child Health at Kolkata. He's always there. Next, we have Dr. Jyotinath Modi. Madam is professor at AIIMS Bhopal, Madhya Pradesh. We have another experienced faculty, that is sir is Dr. Arup Kumar Maji. Sir is professor at Santiniketan Medical College, Bolpur, West Bengal. Then we have Professor Hemangi Chaudhary. Madam is professor at Seth Ziat Medical College and KEM Hospital, Mumbai. We have Dr. Sivli Chanda Chakraborty. She is associate professor at CSS College of OBGYN and Child Health at Kolkata, West Bengal. So I'd like to request the students, Dr. Shruti and Dr. Janupriya, to share their screen, introduce themselves and start presenting. And also I'd like to request Dr. Ashish Mukhopadhyay sir, Dr. Jyotinath Modi, Dr. Arup Kumar Maji, Dr. Hemanga Chaudhary madam, and Dr. Sivli Chanda madam to kindly take over and take the session or examination for the students. Over to you, Dr. Shruti and Dr. Janupriya.
Good morning, sir.
Yeah, ma'am, Jyotinath Modi, madam, you are there? Dr. Arup Maji, sir?
Yeah, present.
Maji, sir. Yeah, sir, good afternoon, sir. Dr.
Yeah,
Hemanga
can
Chaudhary,
you
madam,
hear me?
Hemangi Chaudhary, madam?
Yes, just checking that you can hear me. I'm
Yeah,
there.
ma'am.
Yes, we
Yeah.
can
Thank
hear
you.
you. Students, is it in the slideshow mode?
Yes, sir.
I think so, sir.
Okay. Shruti and Janupriya, you can start your presentation now.
Yes, sir.
Yes, sir. Over to you, all the faculties, please. Yeah.
Good morning to one and all present here. I am Dr. John Priya, second year postgraduate studying in Government Teni Medical College.
And I am Dr. Shruti, final year postgraduate in Teni Medical College. Sir.
Welcome to both of you. Welcome to both of you.
Thank you, sir.
Thank you, sir.
I'm starting
Cool
the
and
case.
calm.
Mrs. Kausalya, 29 years old, female, married since 9 years, belonging to lower middle class family of obstetrics code Gravida 2, Gravida 3, Para 2, Live 2, with previous 2 cesarean section, who had regular menstrual cycles with LMP 12-8-24 and EDD 19-5-25 with 35 weeks plus 4 days of gestation, got admitted in GTMCH on 16-4-25. We examined the patient on 18-4-25. Patient came for regular AN visit and admitted in view of over-DM on insulin and OHA. She had no complaints of increased urinary frequency, no history of burning maturation, no history of discharge per vagina, no history of blurring of vision, headache, epigastric pain and vomiting, no history of increased weight gain, no history of bleeding PV, and she able to perceive fetal movements. First trimester, she conceived spontaneously and booked at Chinnamanur UPHC. Folic acid was started after conception. At 12 weeks of gestation, fasting and postprandial blood sugar levels were done, which showed 153 milligram in fasting and postprandial 230 milligram per deciliter with HbA1c 7%. Urine sugar 2+ and urine acetone negative. Patient was referred to body GH for physician opinion and started on insulin, injection, human atropine, 4 BD along with OHA, metformin, 500 mg BD and on diabetic diet. Other investigations are also done and were within normal limit. Dating scan and NT scan was done and found to be normal. In second trimester, booster dose of TD injection was given at 13 weeks of gestation. At 14 weeks of gestation, fasting showed 170 milligram per deciliter and postprandial showed 224 milligram per deciliter. Insulin dose was titrated to injection had human atropine 8 BD along with metformin. Quickening felt at 20 weeks of gestation. Anomaly scan done at 22 weeks and found to be normal. Fetal echo done and it showed normal studied. At 24 weeks of gestation, fasting showed 104 milligram per deciliter and postprandial 160 milligram per deciliter. As it was maintained, she was on same treatment. In third trimester, fetal movements perceived well. At 30 weeks of gestation, fasting showed 115 milligram per deciliter and in postprandial 190 milligram per deciliter. Insulin dose was titrated to injection human atropine 10 BD along with metformin. At 34 weeks of gestation, fasting showed 130 and postprandial showed 250. Insulin dose titrated to injection human atropine 20 BD along with metformin and patient referred to higher center for further glycemic control. At 34 weeks of gestation, growth scan done, which shows single live fetus corresponding to 34 weeks in cephalic presentation. Estimated fetal weight is 2.8 kg. Placenta is in fundal posterior. Normal fetal parameters with adequate Leica should AFI 15 with normal Doppler. Menstrual history. Patient attained menarche at 14 years of age and regular menstrual cycle. LMP is 12-8-24. Marital history. Patient is married for 9 years and had non-consanguineous marriage. So past obstetric history. She already had 2 alive children. The first baby is alive boy baby. Baby weight is 3 kg. Term emergency LSS done in view of breach in our center 7 years back. Baby is alive and healthy. Second baby is alive boy baby 3.6 kg. Term elective repeat LSS done in private hospital 2 years back. He's alive and healthy. In second pregnancy, patient had history of gestational diabetes at 7th month of gestation and was on insulin and stopped postnatally, and she was on irregular follow-up postnatally. Past history. Patient was diagnosed as type 2 diabetes mellitus and was on irregular treatment, metformin BD, on past 1 year and consulted in private hospital. Surgical history. History of previous 2 LSCs done. Family history. No history of diabetes running in family. Personal history, patient had a mixed diet, normal sleep, bowel, and bladder habits. Allergy history, patient had no specific allergies to any food or drug. Dietary intake, patient is on diabetic throughout the pregnancy. Total number of calorie intake is 2,500 calories per day, in which carbohydrate is 55% and protein 20%. She has 6 meals per day divided into 3 major and 3 snacks. It's a 24-hour recall method. The patient taken for 1 day. Early morning 7 a.m. she had tea or coffee without sugar. At breakfast 8 a.m. she had 3 idlis and lunch rice with vegetable. Snacks at 5 p.m. she had fruits or grams. Dinner 9 p.m. 2 dosas and chapatis. From here, examination will be taken by RPG.
On general examination, the patient was moderately built and nourished with height 158 centimeter and weight 78 kg. The pre-pregnancy weight was 64 kg and her pre-pregnancy BMI is 25.6. With vitals, pulse rate 86 beats per minute and BP 170 millimeters of mercury. Temperature, patient was afebrile and no pallor, no pedal edema, no icterus or no cyanosis seen. Systemic examination, respiratory system, bilateral normal vesicular breath sounds heard. On cardiovascular examination, S1, S2 heard, no murmurs heard. Breast examinations, normal. On per-abdomen examination, on inspection, abdomen uniformly enlarged, umbilicus in central position and flat, linea nigra and stria gravidarum seen, suprapubic transverse scars seen. On palpation, there was no local rise of temperature or tenderness. Uterus, clinically, it was 36 weeks, relaxed, with symphysiofundal height of 36 centimeter and abdomen girth of 90 centimeter. There was no suprapubic scar tenderness. On palpation further, fundal grip, soft, broad, non-ballotable part felt, which is suggestive of buttocks, and lateral grip, irregular knob-like structure on the right side felt, which is suggestive of limbs, and smooth curved shaped structure on left side, suggestive of back. On first pelvic grip, hard globular ballotable structure felt, suggestive of head. On second pelvic grip, the hand was converging, hence it is a cephalic presentation with unengaged head. And clinically, the liquor was adequate. On auscultation, fetal heart rate was regular and heard in the left spino-umbilical line with 146 beats per minute. On admission, we have done investigation, which was blood grouping typing was B positive, hemoglobin of 10.8 gram per deciliter, viral markers, HIV, HBsAg, VDRL was negative, non-reactive. Thyroid function test was found to be normal. Urine sugar was 1+ and urine acetone was negative. This was a fasting and postprandial blood sugar values done throughout her pregnancy. On admission, the last is on 16, we had a fasting of 190 and postprandial was 220 with urine sugar 1+, hence titrated to human ectopid 20 BD and human mixed 6 BD with metformin, along with metformin 500 mg BD. The case summary is Mrs. Kausalya, 29-year-old, G3, P2, L2, previous 2 LSCS, 36 weeks of period of gestation, admitted for high blood sugars for safe confinement. She was a known case of type 2 diabetes mellitus on irregular treatment. And on general examination, her vitals were stable. On obstetric examination, single live fetus with longitudinal light, cephalic presentation with good fetal heart rate present. Her fasting blood sugar was 190 and her second postprandial blood sugar was 220 last and was on insulin and FOGSI. Diagnosis is a case of 29-year-old, gravida 3, para 2, live 2, previous 2 LSCS of 36 periods of gestation, 36 weeks period of gestation, with single live fetus in cephalic presentation with over diabetes mellitus on insulin and FOGSI.
Thank you.
Very good presentation, Dr. Shruti and Janupriya. Very good presentation.
Yes, thank you.
Ashish, Dr. Ashish, you want to talk first? Dr. Ashish, Dr. Jyoti, Dr. Himangi, Dr. Siulu. Good morning to all of you.
Yeah, good morning, Arubda. I think you can start the question to the students and start from the history, please.
Shruti and Janupriya, go to the first slide. Now we'll one by one we'll discuss. First to the history. Then first slide. You have written correctly, but one thing you have omitted here. Which thing that is? That is very important. That is the address of the patient is very important. Address of the patient, because we cannot say the exact address. So the distance of the residence from the hospital, that is very important. You must mention it. You must the address and distance of the patient.
Yes, sir.
Because it is desirable that all the patient must be within reachable distance, not more than 20 kilometers. Then you will have to admit this titration. So this is one thing. And next patient is the go to the next slide. Next slide.
No, Arudha, just before you go to the next slide, I just wanted to ask them why the address was not put in here. Normally, in all the patient details, I mean, identification of the patient, we write the address. Okay.
Yeah.
See, instead of, I would like to ask, what is the importance of writing marital status here? So I think more important than that will be the distance covered by the patient to avail obstetric services, isn't it? Because there are so many complications possible during this pregnancy, and you want the patient to come at regular intervals for antenatal checkup, and also in emergencies, we need to know how much she has to travel to avail the obstetric services at the referral center.
Yes,
Is it okay?
Yes, sir.
Next slide.
Okay. Yeah.
You have written so many important, definitely all the negative point. One thing is, what are the complications of the diabetes? This is a known case of diabetes, we already know. What are the important complications of the diabetes? You have written no history of discharge per vagina. Is there any other importance regarding the vulvovagina?
Sir, as pregnancy is itself an immunocompromised state, and along with diabetes, that poses a increased vaginal discharge infection.
Another symptom. Another symptom, important symptom. What is that? Why there is a itching? So, vulvovaginitis, you must write the negative point, though itching. If there is a itching present along with the discharge, that indicates the persistent vulvovaginitis. Presence of vulvovaginitis means the diabetes is not common. So, that is another important point. Now, next slide you go. Next slide. The first trimester, you have you missed something important thing here? You just see. I am giving you a scope to important thing you have regarding the spontaneous pregnancy, booked the EPSC, and folic acid started, and then FBS, urine sugar, urine acetone, and patient for referred, and other investigations were normal. This is the vague term actually, other investigation. And dating scan and NT scan done and found to normal. But you see about the urine examination, which you have omitted. About the urine examination, what type of particular urine examination you want to know other than the sugar? Because urine sugar is not important, known diabetic sugar may be positive. There is changes. It's a known diabetic. What are the important points? What are the two grave complications of the diabetic mother? The grave complication.
Of preeclampsia.
Preeclampsia is one
Risk
complication.
Other,
in any other thing? The nephropathy. Nephropathy and retinopathy, that is. So nephropathy, in case of nephropathy, and you have to do the urinary protein. Urine protein you must have to mention. And you will have to define that the microalbuminuria, when in this case you should do at the patient has come first, whether there is nephropathy, microalbuminuria, or 24 hours urine albumin. And if it is a grave, that is the end stage disease, that may be the severe albuminuria, more than 300 milligram per 24 hours. So you must mention first whether the albumin is present or not. This is actually gross thing you have missed here. Gross thing you have missed. Next, second trimester, you go. Second trimester.
Can I ask something on this?
Yeah. Definitely.
So you've made the presentation well. You've listed a lot of information in first trimester. Now you tell me, you've written that at 12 weeks, the HbA1c was 7%. What is your comment on that? You can put it in the slideshow. It's okay. Let it be in the slideshow like it was. Let it remain on the slideshow, please.
Yes, ma'am.
Because others will not be able to see. The font size goes down. Yes.
Yeah.
HbA1c is 7%. What is your comment on this? Do you think this is good?
We should explain the risk of congenital anomalies to the patient.
So what does 7% figure mean to you in first trimester with respect to pregnancy?
HbA1c is more than 6.5, it itself signifies the patient has over diabetes mellitus, ma'am. And there is
I will put it another way. This patient is a known diabetic. Agreed? She is known diabetic for a year. If she had come to you before conceiving, what is the HbA1c you would like before she was planning a conception? How much HbA1c you would target and say, okay, now you're ready and you plan a conception?
Yes, ma'am.
HbA1c
of less than 6%.
6% is usual. Yes, 6 to 6.5 you may give, but 6 is the textbook figure of that must be done. With folic acid, is there something else you would like to supplement?
Milligram per day, we should supplement.
What is it? Something else along with folic acid that you would like to supplement? Anything else which has a bearing on neural tube defect? Usually it is folic acid. Yes, that is correct. A smaller component. B12 also is said to have a role. Okay. So that is 2. Third question and final question on the slide is there some, now knowing she's at 12 weeks with this thing, is there any medicine besides folic acid that you would like to initiate now? Something Dr. Arup also asked about, proteinuria and the risk. Is there some prophylactic medicine that you would like to add here?
I am giving you guide. Suppose if
Aspirin.
develop preeclampsia.
What dose would you add?
Preeclampsia.
So for prevention of preeclampsia and growth restriction, what drug you will prescribe this patient?
Yeah, they answered. So what
That
is
is
the dose
recommended
that you
in
would like to
They answered this.
They answered. So what is the dose you would like
They
to
said
give?
aspirin, yes.
Yes, they said that.
Aspirin
What is
150
150. Okay. What is the range of aspirin that is acceptable? The dose. It has to be only 150 or is there a range? Usually we give 150 now, but based on the guidelines and the evidence, what is the permissible range of aspirin that can be given? We say low dose aspirin. What does low dose aspirin mean? So anything between 80 to 150 is taken as low range, but usually we are giving 150 now. But that is based on evidence and guidelines. Okay. So thank you for this slide. Shall we move to the next slide? Are there any other?
No, madam, before you go to the next slide,
yes,
I have got one query in my mind. She's a third gravida, right?
Yes.
When was her last childbirth?
2 years ago.
2 years ago. So I'll be very interested to know what was her, she's a non-diabetic, what was her glycemic control in these last 2 years? Specifically, we would like to know the periconceptional level of blood sugar control. That is very, very important, isn't it? So
Yes,
there are ways and means of doing that. I think she was irregularly treated in the last 2 years of her life. And therefore, there is every possibility that there are some problems in the diabetes control during the last 2 years. And also, she has very irregular antenatal care. So any attempt you have made to find out what was the glycemic control level during the last 2 years, and especially during the periconceptional period, giving folic acid, giving aspirin is okay. But then you have to look at the control also. Looking at the HbA1c figure doesn't look like she was very, very well controlled.
she was on irregular treatment, sir.
Pardon?
She was on irregular treatment, sir.
Yeah. So it's very important to know the periconceptional period level of blood sugar control. And every attempt should be made to find that out in history.
Okay, sir.
Okay.
So in preconceptional period, what should be your desired level of the blood sugar?
Sir, in pre-gestational diabetes, HbA1c
What
should be
is
less
the desired level?
0.5%, and fasting should be 80 to 100.
Fasting sugar?
80 to 100, sir. In postprandial, that should be less
90.
than 155 milligram per deciliter.
So next slide, please. Sir. Next slide. Next slide. Quick.
Yes, sir.
Yes, sir.
The second trimester. The second trimester. And one thing, question is this: is anything you will have to add any other drug? You aspirin will give, folic acid is the, any other medication? Common medication on obstetric cases, all obstetric cases. You have missed
Iron tablets should be started in second trimester, sir.
which drug?
Iron supplements, sir.
Iron supplement you have not given here. You have given the TD, but not the iron supplements. So you will have to give the iron because the standard guideline of the NHM now is the anemia Bhukt Bharat 180 days. That is 6 months before delivery, 6 months after delivery. Yes, then you have to start the iron. You mentioned. And what's about the calcium? What's about the calcium? This is the common question.
Calcium supplements.
Will give or not this patient? And if you give, what is your explanation? And Indian women is actually the calcium deficit. All the Indian, that is what standard guideline by the government of India from the 2016. We must give the calcium supplement, but it is not the international, not the but Indian women. They should be given the calcium.
Yes, sir.
And also you'll have to how the calcium they will take, also iron they will take. So iron, folic acid, and anti-diabetic drug, and aspirin and calcium. So these are the drugs, medication you'll have to totally you have to do.
Yes, it's Arupda has a very
definitely
question. And they should know in detail because they have to advise the patient, right? Now tell us about when do you give iron along with folic acid, what time of the day, what preparation, and what time of the day you give calcium and how much for this lady, and any other drug if it is necessary. You have written about the TD, I think. Injection TD they have written. And they have insisted more on the blood sugar measurement repeatedly time and again. But is it always the FBS and PPBS for control for a known diabetes? There are other methods of measuring the blood sugar on a daily basis, and this is known as the self-monitored blood glucose, SMBG. Okay, so I think that you should specify all these points one by one. What about iron? What iron preparation will you like to have? And when, what time of the day will you advise and how?
Whereas fumarate will be given, sir, 100 mg elemental iron for BED morning and evening dose, night dose. So the calcium should be
fumarate. Any ferrous preparation will be okay. Succinate, fumarate, ascorbate, anything will be okay. Almost the similar. Ascorbate has shown slightly better results compared to others. More importantly, what time of the day will you advise to have iron? If she needs one dose.
Should be given in the morning, not along with milk supplements, sir. Calcium should be given in the afternoon time and the
time. So iron is the best prescribed between breakfast and lunch. Not very empty stomach, not very full stomach. Okay. Because in full stomach, it will deter the absorption of iron. In empty stomach, there will be a lot of side effects, and she won't have it from the next day. So best time is 11 o'clock, and better to advise to have iron with some amount of fruit juice. Why fruit juice? Because vitamin C helps in the absorption of iron. But iron and calcium should never be had together, and calcium has to be taken after meal. What is the dose of calcium?
300 mg. The requirement is 1000 mg, sir, and the supply dose is 300 mg.
300 mg.
2
300 mg.
tab.
Okay. So I think that WHO has recently recommended that if you have a chance for development of preeclampsia, particularly in calcium-deprived women, like in our country, the dose should be 1 gram twice daily. That means 2 tablets each time after lunch and after dinner, after major meals. Okay, Professor Arup Maji has already mentioned about the iron and calcium obligatory requirement in our women. Iron, as per WHO observation, if any country's incidence or prevalence of anemia, iron deficiency anemia is more than equal to 40%, they need to have iron supplementation, irrespective of the hemoglobin status, irrespective of the iron level, etc., inside the body. So you have to remember
Yes, sir.
this. You have to give iron at 11 o'clock with fruit juice and calcium 2 doses in this particular patient because you have already started aspirin. Then you should give it 1 gram twice daily after major meals, and never
Yes.
iron and calcium to be mixed together.
Yes, sir.
This slide, second semester, another important thing is about the ultrasonography. Ultrasonography, now during the anomaly scan, two things other than the growth and the anomaly, two things must see. And here one is very important, that is the localization of the placenta. You mention here, this is not provided to you, but in the second trimester ultrasonography, previous history of 2 cesarean section, you must have the placenta localization. Because if there is a placenta previa, there is a placenta accreta spectrum. Also, length of the cervix. Length of the cervix is also important in any case, length of the cervix. Because if the length is short, less than 20, less than 20, there is a high chance of preterm labor. You will have to prevent that thing. And you will have to remember that thing. So fetal echo, when it will do, fetal echo actually should be the ideal time, fetal echo. Fetal
Sorry,
echo.
sir.
Fetal echo, when will you do it?
Fetal echo 24 weeks, sir.
22 to 24, because now the MTB can be done up to 24 weeks. The fetal echo, as late as we do, that will be better. So next slide. Anything else?
No, Arupta,
Yes,
I think
wanted
I
to
found
ask.
one thing. Okay, madam, go ahead.
Okay. Two questions, one related to diabetes, one not related to diabetes. So the question related to diabetes is, here you've monitored fasting and PPBS. If you were to relook, what would you do? How would you monitor? If you were to, suppose you had a chance of going back to 14 weeks, how would you monitor? Can you go back to the slide, please? Second trimester slide.
Yes, ma'am.
Do you understand my question?
Good question.
You have done only fasting and postprandial. What is the best way of deciding insulin dosage, and how would you monitor sugar?
7-point glycemic profile can be done, ma'am.
Okay, so what is the benefit of 7-point glycemic profile? Because after seeing fasting and PPBS, the only insulin that has been added here is the rapid acting.
Yes.
What is the kind of insulin which is best suited in pregnancy?
Biphasic insulin, ma'am. 30 is
Biphasic means explain the biphasic.
30% short-acting insulin and 70% intermediate-acting insulin is preferred in pregnancy.
What is the advantage of that?
The glycemic control is maintained throughout the day, ma'am, for the pregnant mother.
Short-acting has a peak when? Onset when and peak when? What is the time of onset of short-acting and peak? What is the time of onset of intermediate acting and peak? That is what 30-70 is a combination of.
Yes, ma'am. Short acting is with onset is with 10 to 15 minutes, and the peak action will attain at 1 to 2 hours, ma'am.
Okay, and so about 30 minutes to and peak is around 3 hours. And intermediate?
Intermediate at onset of action will be 1 to 3 hours.
Around
and
1 hour, yes.
8 hours, and duration of action will be 18 to 26 hours. Okay. So throughout the day, the glycemic control will be attained.
So one of the things which could have been done different in this patient from the very beginning is that an initial at least a 5-point profile, if not a 7-point profile, that should have been done, which will help you plan the insulin dosage. Remember, it is the intermediate which provides the basal insulin. For a pre-existing diabetes, basal insulin requirement must be met. Okay. Simply giving like shots of rapid is not going to provide a consistent control which is required. Okay. So basal insulin requirement, these are basal insulins which are met by NPS. Therefore, 30/70 should have been used, or monitoring should be unused. Non-diabetes related question is, what kind of screening is missing from second trimester in this patient? Is it adequate to have only an anomaly scan? Remember, this is pregnancy and not just diabetes. So what are the things that are missing in this patient that should have been done for a screening?
Fetal anomalies from maternal serum alpha fetoprotein can be done. And then
So what kind of tests are those? What is the name of the test which can be used and when? What are the options?
Double marker test can
Done
be
when?
done in early pregnancy.
Done between? Done between?
11 weeks it can be done, ma'am. Protein A can.
If you miss that,
For
what
this
is the other
patient,
test?
14 weeks.
What is the
14
other
weeks.
test? Quad marker can be done later. Is an NT-NB scan done on this patient?
Audible, ma'am?
You are now audible. Has an NT-NB scan been done for this patient?
Ma'am, sorry, ma'am.
Has an NT-NB scan done
nuchal translucency and nasal bone, NT-NB scan.
at 11 to 13 been done for this patient?
I don't think it was done.
NT scan was done for.
Dating and NT were done. Okay. So what we have are the biochemical screening, which is missing for the patient, which should be done at least in combination with one of the tests and target scan. Okay, I think you can move to the third trimester. Yes, I saw.
NT scan. Did you combine the NT scan with the dual markers? That was the question.
Yes, no, they have not done any. I mean, for this patient, no screen has been done. So combination
no
has
biochemical
been
screening
possible.
done. Yeah. Okay. So what happens, most of the cases I find these days prescriptions containing a good prescription for NT scan, but that is not associated with the dual marker because they are not using the app, nor using the FMF formula, and therefore they are doing just the NT scan. NT scan alone is a very poor marker. It has to be combined with a dual marker to have some good positive response with a false positive response within the acceptable limits. Secondly,
and should be also the scoring they should give actually.
Yeah. Scoring.
Combined test. Combined test. And if you miss the combined, then integrated.
That is very because
so
diabetes
all is important in this case. Why?
Congenital.
Yeah. Now let us see what my question was, which Madam also asked subsequently, is there any scope of SMBG, self-monitoring blood glucose? Without SMBG, you cannot have a 5-point or 7-point assessment of the capillary blood glucose. It is impossible to go to a doctor 5 times a day or 7 times a day. So SMBG has to be introduced, and the timing should be before breakfast, that means fasting, after breakfast, before lunch, after lunch, before dinner, after dinner, minimum, these things are. So I think these point-to-point testing. Pardon?
If the patient wants to do less, at least 4. Fasting, postprandial, and pre-meal, and at the bedtime. These 4 at least you have to do. Otherwise, Ashish has said correctly that 6, But for the safe monitoring of blood glucose, at least 2, that is the standard now. That is 2.
So you have to insist on SMBG. Otherwise, this is not possible. And make a chart, make a record, and show it time to time with your doctor. And seeing that, you can see the good control. A patient whose insulin requirement is varying widely. It is not only calculation of the combination of semi-lenti and ultra-lenti 3:7, but also it is more important to see that how this control is having effect on the blood sugar level. And these tests are extremely important in this case.
Another,
So, bolo.
no, another thing from the slide, actually, from that slide. Project the slide, share the slide, not.
Yes, sir.
I think the slide is not shared. Share the slide.
কানেকশনে প্রবলেম হচ্ছে মনে হচ্ছে ওদের, অডিওটা কেটে যাচ্ছে। হ্যাঁ,
Share the slide.
previous slide.
And this is, you are always saying that there is a the patient has insulin along with oral hypoglycemic agent, both oral. And dose
Yes.
you are also given about the later on in the table, the 500 BD always. And what is the evidence about the combined drug, combined insulin and oral hypoglycemic agent? Is it routinely giving, or what is your idea about the?
Sir, oral hypoglycemic agents increases the sensitivity of insulin, sir. Hence, it will be better if we give insulin along
So
with the oral.
there is a trial also, MIG trial also says along with insulin, the better outcome. Definitely.
Yes,
There's also recently large trial also come recently. You can give, but is it really fixed dose of the metformin? How much you can add the metformin? Because your blood sugar is not controlled. It's a 500 only be 1,000. It can be given up to 2,000. You can
2 grams per day. Yes, sir.
insulin and the diabetologist endocrinologist will say along with insulin and what dose you will give, not the fixed dose in the chart you have given. And next slide, please. Next slide. Next slide. And on the third trimester patient, you have admitted the patient. How to monitor this patient after admission? That is very important. You have how will you monitor this patient after admission? Other than blood sugar, anything you want to do? Fetal monitoring. What will you do?
Fetal surveillance should be done, sir.
Hmm?
Fetal surveillance should be done.
You have not mentioned that. Actually, what type of fetal surveillance?
Biophysical profile to be done, sir. If
before the daily fetal movement count and also the
daily fetal
movement by
movement count.
Stethoscope,
Yes,
fetal
sir.
heart rate, and the daily fetal movement count and the biophysical count. This is a common question. What are the components of the biophysical profile? What are the
fetal movement, fetal breathing, fetal body movements, tone, and amniotic fluid volumes.
NST, what is NST? NST?
Non-stress test.
So CTG is also required.
NST and amniotic fluid index, sir.
A5. So this is the common question. Maybe. Now next slide.
Regarding maternal investigations to rule out nephropathy and retinopathy, which investigations you would like to do?
Urine albumin. If it is abnormal, you can go for urine spot PCR or 24-hour urinary protein, ma'am.
Serum creatinine.
Albuminuria or macroalbuminuria, ma'am.
And for this thing to rule out retinopathy?
Fundus examination should be done.
Okay.
That is coming. You are coming at the examination. They are coming at the examination. So next, this is the third time. Next slide. Quick. We are going. Menstrual history, okay. Marital history, okay. Next, the past obstetric history. So you have written the gravida. Gravida 1, gravida 2. Gravida, what is doing gravida? Gravida is not the first pregnancy. It is related with the present pregnancy. Parity and gravida. Parity means all the previous pregnancies after the age of the viability. And gravida means all the pregnancies including this. And this is the way you have added this table after the discussion, today's discussion. But this is not the exact way. You have highlighted only the baby, but not by the other thing. So here you will leave the number 1, 2, 3, 4 like that. And then you write down what is during the pregnancy, during the antenatal period, postnatal period, baby. this sequence that will give a good presentation,
Yes.
not the G1 and G2. G1
Yes,
and
sir.
G2. So baby side will go better to on the right side because you are stressing all the facts also. Mode of delivery you be given. But what's about the pregnancy? What is the during the antenatal period?
Yes,
During the
sir.
antenatal period, the pregnancy event, that is the important. Pregnancy events, internatal event, that is the mode of delivery, whether the labor or not, a cesarean section, and then the postpartum, important postpartum period is very important. And next is the about the baby, you like a 1 column or 2 column. So I think, Ashish, any comment, any other?
হ্যাঁ ঠিক আছে ওরা তো এগুলো দেখেছি they have become very sketchy about the writing the obstetric details. It is more important in any pregnancy, and particularly this pregnancy where there are complications, comorbidities like diabetes mellitus. They should be more careful about writing the obstetric details of each and every pregnancies. That is right.
So next. And here you have written the 7 months of pregnancy. Or the first pregnancy, there is a diabetes?
No, sir.
No, that is the
First pregnancy in and postnatal period anemia and full. In second pregnancy, she had diabetes mellitus, gestational diabetes mellitus.
and first pregnancy was 7 years back. No, 9
7
years.
years.
9 years back and second. So what is about the between the 7 years and 2 years? No, not known actually. Right? Information is.
Yes, sir.
But you will have to inquire whether this was getting irregular treatment or not, like that. The patient is not definitely on irregular treatment.
I want to ask one question. Excuse
Yes,
me, can I
Julie.
ask one question?
Yes, ma'am.
Yes, Julie, bolo.
To Shruti and Janu, what
Yes,
are
yes.
the points for the recurrence of GDM in the next pregnancy? What are the risk factors? Can you tell? She had a GDM in the second pregnancy. Now it is his third pregnancy. What are the risk factors for recurrence? You can say na, the increased maternal age, increased parity, pre-pregnancy body weight, and the previous pregnancy when the GDM arised. When was the GDM first started? At what weeks of gestation? And next is the body weight in previous pregnancy, and the treatment after the in the postpartum period. These are all the factors for recurrence.
Yes, ma'am.
Okay.
The history, have you omitted something in history? General obstetric history, you have some to write. The first childbirth is 9 years back, and second childbirth is 2 years back. So what is about the in between? You'll have to write the contraceptive history.
Yes,
You have missed that contraceptive. This is routine. And another important is the social history. Social history. Now, recently, there is a government has stressed and everyone has stressed about the birth preparedness. Ashish has already mentioned at that time the distance is important, and also what is about the family condition. Who will come to the patient? Who will bring them the patient? This is the number one health issue actually in government of India has stressed that side. So that is the social history is important. Birth preparedness, as well, you'll have to mention the birth preparedness. And here also, my advice is you
Actually,
write down the medication history. Because medication, all the medication you write, this is not
Before you go to the medication, the socio-economic history they have omitted. That is the reason why this thing are not written over here. In socio-economic history, we write the education, the residence, whether rural or urban area, then environmental sanitation and potable water, monthly family income, all these things we write. But they haven't mentioned that. And that is why these things are missing. So socioeconomic history is extremely important. You are right. Socioeconomic history has to be mentioned in all Indian women and write in a separate column.
Yes, sir.
Next. Diet intake, separate.
I want to ask Shruti, how did you calculate the total number of calories like 2500 calorie per day? What is your formulation?
Ma'am, the calorie intake, according to the sedentary or moderate lifestyle, it can be calculated by basal metabolic rate and physical, multiplied by physical quality, activity of life, ma'am.
There are different types of formulations, no? Which considering the BMR and BMI both, and the trimester-wise variation. You must have followed some formulation, no?
Yes, ma'am. According to the BMI, the required calorie intake should be in normal less than 25. It should be 3,000 kilocalorie, 30 kilocalorie per day, ma'am. And if the patient is overweight, it should be 22 to 24 kilocalorie per day. And if the patient is obese, morbid obese, 15 kilocalorie per day is suggested.
And
it is actually 30 to 35 calorie per kg.
Yes, and you have distributed the calories, the calorie distribution. Carbohydrate you have given 55%. Don't you think it's a bit higher side?
Ideally, 40%, 40 to 45%.
Dr. Sivli, Dr. Atis has already pointed out it would be 40%. 40% carbohydrate and 20% protein, and another 40% is the fat.
And that should be also a complex carbohydrate.
Complex carbohydrates are.
I don't know what is the carbohydrate content in idlis. I think that breakfast is too heavy with carbohydrates.
This is the diet.
Now, whatever you write, you'll have to convince the examiner. These calories, because on egg calorie, 100 calorie, like that, 100 calorie, what is the component? You'll have to convert. It's very complicated, but you'll have to convince. What is the amount of calorie?
You should give a good amount of roughage,
milk,
good amount of fibers also.
So, students, can you tell me, so this 2500 you've written is required, or is this a 24-hour recall you've calculated that she's taking? It is not clear.
Yeah.
You've written based on early morning breakfast, lunch, snack, dinner. How much is the actual intake? How much is she taking in? This does not seem to total up to 2500. This is not totaling to 2500.
Any additional thing you all want to give, Shruti, and
so
any additional things you give other than the food?
Sir, it is the calorie intake taken by the
other than these whatever routine lunch, fresh fruit actually.
What is her actual
antioxidant? Antioxidant you will have to give the fruits and vegetables in the form of fruits and vegetables.
Yes.
And they will, whether they will take the sweet or not. That is the sugarless sweet. Sugarless sweet, they are allowed or not. The patient will ask you.
Sweets are not allowed, sir.
No
Fruit juices, sweets, rice, and rare.
That is in tea, whether they will be allowed the sugarless. Sweetening.
They didn't write anything about the fat content.
You can allow.
What should be the...
Now next slide. We'll proceed.
What should be the fat content of the diet?
We have only 10 minutes left now, so I think we should hurry.
Oh.
Judy, let us hurry.
Okay.
We have 10 minutes left.
We'll allow the examination. But manage, we'll have to deliver the patient. Okay.
Go ahead. Next slide, please.
Go ahead. So you write down in physical examination tongue, teeth, gum, tonsil. This is very important because there is a chance of infection in diabetes. Tongue, teeth, gum, tonsil. You have not mentioned that.
Have you mentioned
systemic? You go to the systemic examination.
Yeah. Have you mentioned
systemic examination? Systemic examination. You must write here, particularly in the diabetes, the ophthalmoscopic examination of the eye. Not done or not available. But because they had Dr. Jyoti has said, Dr. Jyoti, that is the nephropathy and retinopathy. Dr. Himangani, I think, said.
Yeah, I was asking whether they have noticed the gait. Is the patient ambulatory? Can she walk? Is her gait normal?
Yes, ma'am. Gait, spine and thyroid examination normal, ma'am.
Gait was normal. You've mentioned it. I don't think I saw that. But... Okay. Okay, it's important to see the gait. Very often we presume that patient is lying down, examine, and when she starts walking, we realize that she is limping. Okay, so it's important to mention the gait.
Yes, ma'am.
Okay, please.
So go next,
Yes, ma'am.
next, quick. Next, Shruti. Next slide. Okay. Uterus 36 is better
Yes,
to
sir.
write fundal height 36. Eh? Fundal height 36. It's okay.
Yes,
Anything
sir.
else? Next. Next slide. Achha, before investigation, do you want to inspect the vulva vagina in this patient? Is it important? I think there is a problem of the net connection. No?
Yeah.
Vulva and vagina infection, is it important in this patient? Because
Yes.
candidate vulvovaginitis is the complication. I have already pointed. So not only you the postgraduate exam, you are allowed to do the per vaginal examination. Only inspection is sufficient here. This is not in labor. Only inspection
Okay.
is sufficient. So that you must write. Next.
No, I would also like to add a part speculum examination.
Yeah.
Examination, but a part examination the vulva vagina and also speculum examination.
Yes,
You know,
sir.
sometimes the leaking goes undetected, and patient doesn't complain about it. And also there are some signs and symptoms of vaginitis which you need to see. The cervix needs to be seen. I think the part speculum examination by a gentle Casco's speculum is important. It's part of routine examination.
Yes, sir.
Okay, so I think you people have put too much of stress on the blood sugar measurement, isn't it? And the only thing that you manage.
They have pointed actually the hypoglycemia in pregnancy.
Yeah.
Topic.
You need
But
to have
you
a
must remember
comprehensive.
all the other things also be asked in.
The comprehensive care of the mother, the birth preparedness and comprehensive care of the mother demands that you should take care of all the systemic problems that she may or may going to have in the future, anticipate them, inquire about that. So examination doesn't only mean that the capillary blood glucose you estimate 5 point or 6 point or 7 point, but also look after the general well-being of the woman, you know, other symptoms, etc., and the thorough examination of the mother.
Yes, sir.
So go to the next slide. Next slide, quickly. So this is the case summary. So okay. So what is our fetal heart sound is written here? Fetal heart sound, fetal heart rate. You have written the FHR. FHR cannot be looked here. It will be fetal heart sound. Go to that slide. Fetal heart rate. Auscultation. Auscultation. FHR you have written. It will be FHS. Fetal heart sound.
Yes,
FHR means fetal heart rate. Fetal heart rate 146. What you write down here? FHS present in the left shoulder. FHS. Okay, quickly.
Yes.
Go to the diagnosis. Okay, you have said. Now, how will you manage this case?
Anemia is missing from this again, 10.8 hemoglobin.
Yes, ma'am. The management of this case is the patient is previous 2 LSCs with 36 weeks of gestation and the sugars is uncontrolled, sir. And hence I'll do biophysical profile and I will plan for elective LSCS at 37 weeks. If it is uncontrolled, it will plan it early, so 36 to 37 weeks. After
when you
advanced
do 37 weeks. So you will monitor maternal monitoring, fetal monitoring, and you will deliver in 35. Mode of delivery?
And so is 2 LSCs. It's planned for elective repeat LSCs.
So you will do the elective cesarean. You will do the
What about
want
the
to-
pulmonary maturity of the baby?
Yeah.
We
That is
Seven
important.
consider
in a diabetic
you
and that too an uncontrolled diabetic. Surti, can you
You want
answer
to
that?
give the steroid or not?
Or this side.
As from in diabetic
Yes,
mothers, there will be
Sorry?
in diabetic mothers, there will be reduced, inhibits the cortisol level and there will be reduced surfactant production. Hence, the baby is prone for respiratory distress, ma'am. So, we'll give an
So-
AN steroid course for that patient, ma'am, before planning for electrolysis.
Yes, so because patient will be admitted, you can give and you can actually control the sugar.
You will give steroid or not? This patient?
We'll give steroids, sir, but we'll increase the dose, insulin dose by
Yes,
2 units.
you will monitor and increase, adjust the dose accordingly, whichever point. So at this time, she'll be admitted and you will be doing the 5 or 7 point charting in hospital and titrating the dose accordingly. Okay.
Yes, ma'am.
So if you're
Do you
delivering at
know, Shruti?
37 weeks,
Huh.
you have to be sure that she is covered with the steroids. Okay.
Steroids. Yes, ma'am.
Do you have any idea how the dose of insulin is monitored after giving steroids?
Very good question, Suli.
There are actually
There
different
you will have some
formulations,
idea.
huh?
Just I am telling you, the day one you increase the 25%.
Yes, this
You
is
want
Irish
the-
formulation. Yes.
Because you are giving the meat. And day 2, day 3, all doses you increase 40%. This is the
Yes, sir. Yes,
4 to 5
exactly.
weeks. And D4 for all doses 20%. And
And
D5
day 6.
10%. So these are the tapering the dose. You'll have to
And
increase.
yes, sir.
The
Exactly.
problem of steroid is that advantage is the baby maturity and disadvantage is the unstable glycemic control. So you will have to balance of this.
If someone
Now,
is on
pre-operative
metformin only,
cesarean section, the counseling of the patient before the cesarean section, what will you do? That is very important question.
So, the night dose of
Which patient?
basal
Your patient.
taken by the mother and the morning dose will be omitted. The fasting serum electrolyte should be done for the patient and it should be posted as first case in elective LSA so that the patient may go for hypoglycemia.
Now, how will you counsel? What are the different aspects of counseling of the patient and party relatives? This
Sorry,
is
sir?
the prior repeat stage. Am I audible?
Yes, sir.
I'm
Yes,
audible.
sir. Yes, sir.
This is the prior repeat stage. You are doing a diabetic seizure. So when you will plan to do and how will you counseling the patient?
I'll come.
First, we should explain the attendant about the risk of that repeat cesarean section itself, sir. We should
The complication of repeat stage.
explain about
On another thing, so we will have to give reserved blood. Or you have to talk with the blood bank. The blood may be needed, one thing. And next, then the counseling regarding the fate of the baby. Because babies, there may be complications of the baby. They already said there are RDs. Already you will have to the hypoglycemia, hyperbilirubinemia, hypocalcemia. And also there is a chance of congenital anomaly. There may be overlooked in the duty use. So these are the things you will have to tell them.
and the future contraception.
The contraception we are coming. Before that, what are the during cesarean section and what is about the insulin dose?
So the glucose monitoring to be done and it should be maintained within 70 to 110, sir.
पता है जमा
And
की
the-
गोली ने अगर बैग नहीं नीचे में बड़ा तो नहीं बोल दिया काल के थोड़ করে দিবে ये ना खूब मुश्किल है तो
Ashish, please mute. Ashish, mute.
Yes.
I think you are in the Viswamangala. One thing is that you before night, then a normal dose, a light. In the morning, omit the dose and titrate the dose. If it is needed, you give the regular insulin. Yeah. Regular insulin you give and titrate that with the IV flow. And monitor at the morning you monitor 1 hourly CBG
Yes,
monitor and consult with the anesthetist. He is the main person, anesthetist and the pediatrician. And this is the elective cesarean section. There may be something the floating head also for problem of floating head, problem of the delivering the baby. That is the technical aspect in our group. Now, Sivli was asking about the contraception of this patient. Dr. Sivli was asking about the contraception of the patient.
That should be in the part of the counseling also. Because repeat CS usually do ligation.
Yeah, counseling
but
on
if patient
important.
is not willing for ligation, what should be the alternative?
This patient, what will you do? Repeat cesarean section.
Sir, it is the previous 2 LSCS. The patient is having 2 live baby. I will counsel her for permanent sterilization, sir. Even though I'll explain the risk of respiratory distress and post-neonatal complications of the baby. If the patient is not willing,
he has 2 living baby. So what will you do? Contraception? So you offer
permanent sterilization, sir.
Permanent contraception. This
permanent sterilization, yes, sir.
Still the baby is now not a problem now. Permanent contraception, that's the tubal sterilization. And how will consent taken? What is the guideline regarding the consent of tubal sterilization during cesarean section?
Sir, sorry, sir.
During cesarean section, before cesarean section, how will consent will be taken? Is there any guideline in India? There is a RCOG guideline. You will have to take the consent 1 week before. But Indian no such guideline. But pre-operatively you take the consent, the ligation.
Yes, sir.
The wife consent is enough. But for Indian people, it is better to take the consent of the husband and the family.
Yes, sir.
Because the birth right. Yeah. Now come to the postpartum period. What will you do?
Postpartum CBG monitoring to be done for the mother every 4th hourly, sir.
What will happen to the insulin requirement as soon as
during the postpartum period? Happen to the insulin requirement.
Sir, I will look for CBG monitoring every 4th hourly as the patient was over DM and was on high dose of insulin. 1/3 of the insulin dose can be given, sir, which was
now, madam is asking you one question. What is the about the glucose level after immediately?
What will happen? What will happen to glucose levels or insulin requirement?
Insulin
requirement will be reduced postpartum.
Insulin
requirement will be reduced postpartum.
Yeah, usually 24 hours, no insulin requirement is needed. What is given in the during the OT, the consultation was there. Then you adjust the insulin. Minimal insulin, you keep some in the hyperglycemic level, not the. Then
so, Dr.
after that,
Dr. Sorry.
Then after that.
Yeah, after you.
If it is under control, then after 3 days, after starting diet, I'll plan for fasting and postprandial, sir, and I'll accordingly manage with insulin or
Tell me, how will you write fluid orders? She has just undergone cesarean. You're writing post-operative orders. What will be your fluid orders for such a patient?
Good question.
Better to avoid DNS, but if the patient CBG falls in hypoglycemic range, we can start on DNS.
If you give DNS, how can it be given? See, remember, she is not a GDM. She is a pre-existing diabetes. So her tendency will, whether you give DNS, dextrose-containing fluid, or saline, her tendency will be to have elevated sugars. So how will you give the fluids? It is better to give a dextrose-containing fluid, but with something else. What can you give to keep a control? That is also a way of administering insulin to these patients.
Yes. Watch for DKA and CBG fall. CBG is higher with insulin on 5% dextrose. I'll give insulin infusion.
How will you prepare? So the drip is known as a GKI drip. What is a GKI drip? Glucose and what else is there? If you have a DNS and you're So that has some glucose. You're adding insulin and you're adding potassium. How does potassium help? K is for potassium.
Insulin causes hypokalemia, ma'am. So to prevent that, potassium is also supplemented.
This has something to do with the pump. Potassium and insulin both can be pumped together. That is why GKI is added. But the amount of neutralizing insulin, the amount of insulin you add to a drip which is containing dextrose is known as the neutralizing dose. Based on the blood glucose levels of the patient, you decide the neutralizing dose of insulin. If it is patient is in euglycemia, you add 4 to 6 units to 500 ml. Okay, because that is the amount it comes down to. It's beyond the scope of the discussion to go into how much glucose and how much, but roughly 4 to 6 when a patient is in euglycemia. But if the patient is in hyperglycemia, the amount of neutralizing insulin you will add will be higher. So please read up about GKI drip and neutralizing drip, because that is going to be the cornerstone when the patient is on fluid therapy, at least for the first 6 hours before she starts orally additional fluids.
Yeah, I think they should learn about the neutralizing dose, because in places where the anesthetist, usually you consult the anesthetist, and they will also opine about the IV fluid therapy. But in cases where DNS only is available, nothing else is available, then they need to know about the neutralizing dose of insulin, which has to be added to each bottle. We have another 5 minutes or so to wind up this case. And there's a slight change in the schedule today, because Dr. Subhas Malia is in the airport now, and therefore we need to take up the quiz first. Archana is ready with the quiz, so let us wind up the case in 5 minutes. Okay, madam.
Okay.
And
One
Dr.
thing is
Arun
that what about the contraception and permanent sterilization other than permanent sterilization? But it is a lot of controversy about the contraception. What is the recent opinion regarding the contraception? Diabetes, non-diabetes. Contraception.
Contraception. I use a counselor for permanent sterilization, sir.
Another contraception?
For IUCD, sir.
IUCD. Another?
Anything to consider before giving IUCD?
Anything considered before IUCD? Barrier contraceptive you advise. Barrier contraceptive.
Yes, sir.
So, and the other LARC also you can avoid. The implant and
yes, sir.
And oral contraceptive you can give. Combined oral contraceptive, can you give or not?
It's according to medical eligibility criteria for contraception, it belongs to category 4 for type 2 diabetes mellitus and complicated.
Your patient will give or not? Suppose he is asking for oral contraceptive. When it can be given or it cannot be given. If this is associated with the vasculopathy, you cannot give. But otherwise, if there is no vasculopathy, you can give. And if the vasculopathy, you can suggest the progesterone that you can give. So almost all contraceptives can be given with strict monitoring and investigation, rule out the other contraindications. Almost. Previously, it was said don't give the IUCD and don't give the other oral combined.
I think in this case, Arubda, since it's a repeat cesarean section case, she had 2 cesarean sections before, and patient should be adequately counseled. Patient and her husband should be adequately counseled about permanent sterilization, say 3 to 4 days at least, because you have to give them some time.
Now we have discussed, Aziz, you are there. We have discussed about that.
No, I'm coming to that. I'm not talking about that. I'm saying if they do not agree, then the better method of contraception will be PPIUCD inserted during the
PPIUCD
section. Yeah.
PPIUCD no contraindication. You will have to give the expert person. PPIUCD can give.
Okay, so I think we will now wind up the case. And I would like to thank you very much, Dr. Hemangi, madam, Professor Arup Kumar Majhi, and
Dr. Suruti and Dr. Janukpriya.
Other faculty members? The
Right.
other
Dr.
faculty.
Santa, Dr. Santa, you are silent, but your students have done
yeah,
very well.
Sir.
Very well.
Yes, sir. I wholeheartedly thank the ICOG chairperson, Dr. Bharat Bingwali, Ashokma sir, and Hafiza sir, Ashish sir, and Jyoti madam, Arup sir, for
Yes.
your wonderful inputs
Jyoti.
for our students. It will be a great boon for our students, sir, because we are from a small town in Tamil Nadu, and it will be a great encouragement for them. And you have all suggested many valuable inputs for all our PG students. So thank you so much for all your
Thank you,
values.
madam. The size of the town doesn't matter, but your students have done exceedingly well, and they have taken great care of the trying to put in the
Yes, sir.
most available facts and figures. Just reorienting them and redirecting them will help. They have done a wonderful job,
Thank you, sir.
and all these questions we do over questioning because we don't want to our students to fail in the examination facing some unknown question. That is why we go a bit further. Otherwise, they have done very well in the case presentation. So I thank all the faculty. Yes.
Last advice to the students. Last advice. My last advice. You will not get so much of time to write the examination. So within 30 minutes, you will have to complete all the things within 30 minutes. So it is the practice. All of you practice about the obstetrics case and gynae case. Writing down 3 to 4 cases of the each case. You do practice, then you will be able to with the time. And don't leave the khata. Don't leave your answer script without writing the summary or provisional diagnosis. It happens sometimes, but you will have to give the provisional diagnosis. So it is a practice, only practice. So thank you all. Thank you.
Thank you.
I think all of you passed. Definitely all of you passed. Thank you, Ashish.
It is my pleasure to see so many learned faculties together and taking up the examination of a difficult case, complicated case. But I think these will be stored in the website. And madam, your rest of the students can access the website and to see this interaction going on between the teacher and the students. Okay. And remember that whatever you write in the history sheet, you have to write quickly. Not only that, you have to practice it, reading it out 3 or 4 times, because when you present the case to the examiner, the history sheet is taken by the examiner. You have to speak extempore. Remember that. So start certain facts and figures, keeping them to the minimum, and presenting your case to the examiner is very, very important. And that is the need of practice here, which Professor Arup Maji has just now said. So thank you very much, all the faculty members. It was a wonderful session. I would like to close this session here with the remarks that your students have passed with flying colors. Thank you very much.
Dr. Archana, good afternoon. Dr. Toru, after a long time. But Archana, I met recently, but Dr. Toru, can you remember?
I met Dr. Ashish sir yesterday only in Kolkata. I was there for VPCon. Wonderful conference going on. I had to rush back to Ranchi for this quiz only. Otherwise, I would stay today also.
This shows your dedication towards FOGSI and all FOGSI and ICOG events. Archana, are you ready with the quiz? Then
yes, sir, I'm ready. So, because there was little change in the schedule, I don't know whether the students are ready or not, but I was ready with the quiz. I'm sharing my screen.
Yeah. Start the registration process immediately. Okay.
Yeah.
Thank you so much.
Thank you, Ashish.
Thank you so much, Arudha. It was our pleasure very much.
So, are you able to see my screen?
Yes, it is opening. It is not yet open.
Yeah, it is opening. No? It is not yet open.
Yes, it's opening.
Yeah, it is. Why it is taking so much time? I don't know.
Archana, you are working from where? From office? Do you have a Wi-Fi connection?
Yeah, sir. I'm working from home, but there is Wi-Fi connection.
Okay.
So maybe I'll stop sharing and reshare.
Yes, ma'am.
I think so. Yes.
I'll reshare. It was coming up. I don't know what happened. Okay, that login. Just give me a minute. Yeah, it is coming as loading, but I don't know why it is taking too much time.
You can log out and rejoin, Archana. That may help.
Yeah, that is what I'm doing, sir.
Okay.
So it is visible now?
Not yet.
But
Now it is visible. Now it is visible.
visible, no? The game pin is visible?
Yeah, game plan is visible now.
Yes, ma'am.
Yeah, but so dear students, today is going to be a very exciting quiz on the topic hyperglycemia and pregnancy, which is very, very important topic for all the postgraduates. How to log in, I think most of you would be knowing, but just to reinforce, you can see there is a game pin 56246. So you can just, if you have Kahoot app, you can just download it and enter the game pin, or you can join at the www.kahoot.it, and again you can join through the QR code also. You can join through game pin. So I can see many of the participants are now coming up. So I'm just wait for a few minutes, I mean, for them to join. So today I'll be the quiz master, and along with me, Dr. Taru Chaya, very dynamic quiz committee member from Jaipur. Dr. Taru Chaya has also joined with me. And I must acknowledge the efforts of Dr. Taru Chaya as well as Dr. Jayashree Beatkar, who contributed the question. And I am also very much thankful to Ravi, who is the South Zone coordinator of quiz committee, for helping me out in putting this quiz into the Kahoot app. And he could not join because of some prior commitments. So we can see 32 participants have already joined. We'll wait for 5 more minutes maybe. Hello? Right now I'm in a Zoom meeting conducting quiz. Can you call me later? Okay.
Around 40 participants are there now.
Yeah, 40, 41. So we'll wait till 50 if possible. Then we'll start. So who has joined as you? Please mention your full name at least. Don't put abbreviation U, V, I can see. How we are going to identify? And all the participants, it is better if you put your name, because at the end, podium will be displaying your name, and first, second, third will be getting prizes from ICOG. And I'm very much thankful to ICOG President, Chairperson Dr. Parag Biniwala for this endeavor and this gesture of him. So I'm not going to lock the quiz. That means if more participants are coming after I start the quiz, they can still go ahead with playing the quiz. So I think, shall we start, Ashish sir? Shall we start? Taru madam, are you there?
I think they are 50, more than 50 now.
So I'm going to start. So here we start the quiz. So this is the PG ICOG quiz on hypoglycemia and pregnancy. 3, 2, 1, and here we start. So this is the round 1 on preconception care and diagnosis. So what is the lifetime risk of developing type 2 diabetes after a GDM pregnancy? 10 to 20%, 20 to 40%, 40 to 70%, or 80 to 90%? So quickly the answers are coming. And I think all of them have answered now. And let's see the scoreboard. The correct answer was 40 to 70%. And I think only 22 people could get it right. Well done anyway. Next question. And this is the scoreboard. Mr. Barber is leading the scoreboard. Anyway, the next question, how will you screen a woman during pregnancy for hyperglycemia after bariatric surgery? Is it 75 gram OGCT or 100 gram OGTT or glycosylated hemoglobin or 50 gram OGTT? Okay, the correct answer was HP1AC, and I think almost half of them have got it right. That is very nice. And this is the scoreboard showing little change. Swatika is now at the top. So next question is true or false. WHO cutoff for diagnosing GDM is 92, 180, 153 at fasting 1 hour, 2 hour level. So just you have to tick true or false. Now we have 61 people logged in, 63. Almost all of you got it right. This was pretty easy. So the answer is true. And here's the scoreboard again showing the same person at the top. The next question is again true or false. DIPSI recommends a universal one-step screening to be done 3 times at the booking visit at 24 to 28 week and at again 32 to 34 weeks. Now, is this statement true or false? This is again a very simple and very basic question. This is the correct answer, and only 38 people got it right. So the scoreboard again, Swatika is at the top. The next question is again true or false. Glycosylated hemoglobin is a reliable test for screening. True or false? This is again a very basic and simple question. So the answer is false. And I don't think most of you got it right. But I was expecting more correct answers from all of you. Again, now this is Samasti at the top now. Swatika has the 3rd position. A patient with pre-existing diabetes is planning for pregnancy. The most important aspect of her preconception care is starting her on insulin therapy, ensure blood glucose control with target range, increasing carbohydrates in the diet, discontinuing metformin if she was taking previously. This is again a very simple question. The correct answer, ensure blood glucose optimize the blood glucose control within the target range, and most of you got it right. I'm very happy with this response. So let us see the scoreboard. Again, Samasti is at the top. Next question. MODY, that is maturity onset diabetes of the young, is most commonly inherited as autosomal dominant, autosomal recessive, X-linked recessive, or mitochondrial. The answers are pouring very quickly. We have 4 seconds left. Yes, the correct answer is autosomal dominant. Half of you got it right. Let's see the scoreboard. Again, Samasti is at the top. The next question, which statement is true regarding GDM diagnostic protocols? ADA recommends two-step testing with 50 gram GCT followed by OGTT. WHO recommends only glycosylated hemoglobin for diagnosis. IADPSG recommends fasting 1 hour, 2 hour glucose after 75 gram. DIPSI uses fasting 100 gram glucose test. Yes, the correct answer was the one printed in yellow. International Association of Diabetes in Pregnancy Study Group recommends 75 gram oral GT with fasting 1 hour and 2 hour glucose level, and at least one of them should be normal. Let's see the scoreboard. Huge change now. Nidhi has jumped up to top. Next question for this round is GDM diagnosis in twin pregnancy should follow higher threshold than singleton, only fasting blood sugar, OGTT is not recommended in them, or it has the same threshold as singleton. Yes, most of you got it right. It has the same threshold as singleton. There's no change in the diagnostic parameter if the gestation is twin pregnancy. So let's see the scoreboard again. Nidhi is again at the top. I think this would be the last question of this round. Aneuploidy screening in first trimester is affected in GDM. So regarding this, which of the following statement is correct? Papa A level are increased, beta HCG level are decreased, both Papa A and beta HCG are decreased, both Papa A and beta HCG increased. Sorry, most of you did not get the correct answer. The correct answer was both Papa A and beta HCG are decreased. Let's see the scoreboard. Again, Swatika has jumped to the top. Next question, we come to the round 2, which is on management and postpartum care. So here's the first question for this round. You are going to see an image and you have to tell me what does this pattern suggest. Is it just the poor diet control, or this requires insulin initiation, it shows accurate control, or it needs a repeat of the test? So the correct answer is it reflects poor diet control only, because only the 1 hour level was disturbed. So that can be managed by diet only. So I think only few of you got it right. And the scoreboard shows Swatika again at the top. Nidhi, Swatika and Samasti, I think they are competing among themselves. So here is a 34-year woman on insulin for GDM, and she has persistently elevated postprandial blood sugars, but normal FBS. So which insulin regimen is best? I think you can read it out on your own and answer. So the correct answer is give a basal dose, basal bolus with rapid acting post meal. Basal insulin has to be given for the background control, and then we need to give rapid acting post meal for postprandial blood sugar control. So I think most of you, half of you got it right actually. Anidhi is again at the top. So next question. Which ultrasound parameter is most useful in identifying fetal macrosomia and diabetic pregnancy? Again, an easy one. Is it BPD, femur length, AC, or AFI? Yes, the correct answer is abdominal circumference, and I think most of you have got it right. I was expecting this because it is a very simple question and a basic one. Again, Nidhi has jumped to the top, followed by Swatika. Next question. In GDM with good control with insulin and no complications, induction of labor is recommended at before 37 week, 37 to 38 week, 38 to 39 weeks, after 40 weeks. Well, the correct answer is 38 to 39 weeks, and 50 people got it right. That is a tremendous response. Swatika again at the top. Next question. Which of the following is true concerning management of overt maternal diabetes in second trimester? So all these women should undergo amniocentesis. They should undergo a fetal echocardiogram, have higher rates of chromosomal abnormalities, should be offered genetic screening if more than 35 years of age. I think this part was being discussed during case presentation also. Yes, I am happy that most of you have got it right. They should undergo a fetal echocardiogram at 22 to 24 weeks, as Arup Maji sir was explaining to you. Here is the scoreboard. Swatika again at the top, followed by Nidhi. Next question. What is the most accurate method to initiate insulin dosing in a GDM pregnancy requiring therapy in third trimester? So you can read the answer on your own and answer. The correct answer is weight-based split mixed insulin regime. That means you have to split the insulin doses into 2/3 morning, 1/3 in the dinner, and again the morning dose to be divided into long-acting and short-acting. So let us see the scoreboard. After this question, again Swatika is at the top, followed by Nidhi. Next question, which of the following glucose pattern in GTM patient is most concerning for fetal overgrowth or fetal macrosomia? Yes, the correct answer is postprandial hyperglycemia throughout the day predisposes to fetal macrosomia, and I'm happy that most of you have got it right. Here's the scoreboard. Not showing much change, remaining the same. This question, which woman is least likely to require pharmacological therapy for GTM? BMI 35, GTM diagnosed at 24 weeks, age 38, high fasting sugar, PCOS with high fasting insulin, BMI 24, postprandial blood sugar in the range of 120 to 140 milligram per dl. Yes, the correct answer is women with BMI 24 and postprandial blood sugar in the range of 120 to 140 milligram per dl. Most of you got it right. And here's the scoreboard, not showing much of the change. Next question, which is true regarding metformin in pregnancy? It is contraindicated due to teratogenicity. It crosses placenta but not associated with teratogenesis. It increases the risk of fetal macrosomia. It is preferred in GDM detected after 28 weeks. Yes, the correct answer is metformin crosses placenta but does not cause teratogenesis. And there are few evidences which suggest it decreases the risk of fetal macrosomia as well. So here is the scoreboard. Again, it is remaining the same. Next question. What should be the next step in managing this pregnant patient? You are seeing this picture of retina and you have to tell me the correct answer regarding management with this ophthalmoscopy picture. So the correct answer is she needs referral to ophthalmology and regular monitoring. And almost half of you got it right. So again, persistently, Swatika is remaining at the top, followed by Nidhi. Breastfeeding in women with GDM has been shown to increase postpartum insulin resistance, delay milk production, increase the risk of neonatal hyperinsulinemia, or reduce maternal future diabetes risk. So the correct answer is it reduces maternal future diabetes risk. This is one of the most important advantage of doing the breastfeeding. It decreases the insulin requirement as well. And I'm happy that most of you got it right. And here is the scoreboard. Swatika again leading, followed by Nidhi. What is the recommended postpartum care for a woman with GTM? She should be screened for type 2 diabetes at 6 weeks postpartum, or she should be put on insulin therapy for 6 weeks, requires lifestyle management only, screening for hypertension at 12 weeks postpartum. Oh, wonderful. All of you have got it right. She definitely requires screening for type 2 diabetes at 6 weeks postpartum. So here is the scoreboard. Swatika again at the top, followed by Nidhi. And AP, I don't recognize the name, but anyway. So we come to the round 3, which is a few questions on complications of diabetes. And I think Dr. Taru Chaya, madam, are you ready to take this round?
Yeah.
So I'll be just displaying the questions and you have to.
Thank you, Dr. Archana. So in this question, which trimester has the highest risk of maternal hypoglycemia in type 1 diabetes? First, second, third, or postpartum? Everybody is answering very nicely.
Yeah. This time the response is very nice.
Oh, this is.
But they I think they got it mistaken for hyperglycemia or something. Only 18 people can get it right. Anyway, so here is the scoreboard.
Swatika is still at the highest. Now, why does polyhydramnios occur in diabetes during pregnancy? Because of placental insufficiency, reduced maternal fluid absorption, increased fetal urination, or fetal renal agenesis.
So the correct answer is increased fetal urination, and most of you have got it right.
Very nice. Maintaining the first position, Swatika, congratulations.
Next one.
Neonatal hypoglycemia in GDM is primarily due to maternal insulin crossing the placenta, fetal pancreatic hyperplasia, birth trauma, or delayed cord clamping. Now everybody knows hyperglycemia.
Yeah. This is an easy one.
Answer should be 100. No, only 36% were correct. 36% were wrong. So let's see who won the place.
Yeah, now the second position has changed.
Second position is changed.
Next question.
Which maternal complication is most likely to occur in a woman with uncontrolled diabetes? Gestational hypertension, hypoglycemia, UTI, or preterm labor? This was also a discussion in this case presentation.
Yeah, this is again a very common and a very important question. Oh my God.
I think positions will change now. Gestational hypertension should be the correct answer.
So let's see. No, Swatika got it right, and Nidhi again maintained second position.
Yeah. Which of the following is least likely to be associated with diabetic macrosomia, polycythemia, neural tube defects, and oligohydramnios? Least likely. Be careful. Wow, very correctly answered by everyone almost. Oligohydramnios is the correct answer. Next question. Which fetal cardiac abnormality is linked to poorly controlled diabetes? When the diabetes is poorly controlled, which cardiac abnormality will be concerned? VSD, cardiomyopathy, transposition of great arteries, PDA, patent ductus arteriovenosus.
Yeah, the correct
The correct answer is cardiomyopathy. VSD otherwise also happens.
Yeah.
It's not related to poor control of diabetes. Sorry, people.
So here is the scoreboard.
Swastika again at the same pace.
Yeah. Next question.
Ultrasound image showing polyhydramnios and fetal AC more than 95 percentile. What does this mean? Most likely, what will be the diagnosis? Fetal anemia, fetal infection, GDM-related macrosomia, cord prolapse risk. There is polyhydramnios. AC is
again a very easy one. I think
very easy
one
question.
person got it wrong. This was a very
good, very good. Everybody's.
So we have to make a mix of little easy and little average and little high level questions.
So that everybody can answer.
Yeah. So again, Swatika and Nidhi are maintaining their positions. Next question.
Which is considered a reason for sudden fetal demise in women requiring insulin during pregnancy? Non-ketotic acidosis, elevated lactic acid levels, decreased hematocrit in fetus, none of the above. What will happen when hyperglycemia is there? Very good. 39% answer correctly. Elevated lactic acid levels. Dr. Archan, that means they're reading hyperglycemia correctly.
Yes. So again, the scoreboard, we need not emphasize. This is
Compared to women without diabetes mellitus, which condition occurs more often in setting of pre-gestational diabetes? In concern with pre-gestational, stillbirth, perinatal death, PPH, gestational hypertension. If I say maybe repetition of the question. Yeah, now this time most of the students participated are giving 37% only give the correct answer.
Yes.
Swastika again on the top.
So I think this is the second last question. Yeah.
Which of the following factors are implicated in fetal macrosomia? Leptin, peptide, ICF, all of the above. Correctly answered. Only 5% were wrong. 6%. Everybody answered correctly.
So leptin, C-peptide, and insulin-like growth factor are all related to fetal macrosomia. So I think we come to the scoreboard. That is the end of the question. That is the end of the quiz.
Yeah.
So let us see the podium.
Number 3, Nidhi. AP, please open your name. What is your name, AP? Swastika, congratulations.
So I think I can stop sharing and go back to the Zoom. So that was very interesting quiz. I think how we can allow the speakers, I mean the winners to come in the Zoom platform, I don't know. Actually, these are all faculty linked. So can you, I'll just announce the name, Swatika, Nidhi and AP. So can you write in the chat box? Who is AP? At least you can write in the chat box. Can the technical person help me whether they can write in the chat box or not?
Maybe chat boxes for faculty.
They have separate link, maybe. Yeah, they can write it here. I can't see them. How they can? They cannot join because they get a separate. They cannot. They get the separate Zoom link for the audience. No, but anyway.
I just.
Yeah. So, good afternoon, Dr. Sok sir.
Good afternoon. So
yes, sir, we have come to the end of the quiz.
Yes,
and we have announced
it was
the
a
winner.
it was a very interesting and a very informative quiz. Good questions were there, and congratulations to all the winners.
Yes, sir. But actually, we are not able to get the name of the third one. AP, he was abbreviated as AP. I
Taru
need
has
to know.
mentioned just now. Dr. Taru has mentioned Nidhi.
Nidhi and Swatika, but the third one was abbreviated as AP. So we are just asking to write them their detail maybe in the chat box. Yeah.
We will ask our backup team to
take a
see the
technical
phone
team will
number
help us.
phone number or email what they've logged in. So then we will let you know.
So I will be needing their technical support person. I'll be needing AP is Aparajita.
No,
Okay. So I will need their phone number and email ID to and their address also. Maybe.
So our backup team will give you. Yeah.
Yes, sir. Thank you, sir. Thank you so
thank
much
you
for
very
the
much, Dr.
opportunity.
Archana. Yeah, thank you, Dr. Archana and Dr. Taru.
Thank
Thank
you
you
so
very
much.
much for conducting the quiz. And it is becoming a very popular part of
Yes,
our
sir.
IC.
This time many people were logged in quickly. Actually, last time we were having some problem. But this time 71 participation was quite a good number.
Yeah. So, Dr. Hafiz, we can continue with our next program.
Dr. Subhash Malya's.
Yeah, Dr. Hafizur Rahman, if you are online. And let me check if Dr. Subhash Malya is there or not. Dr. Ashish sir, you want to say something to conclude the sessions? Then we will left only with the Dr. Subhash Malya session.
Sir, Subhash is joining.
Dr. Hafiz, yes. Meanwhile, you can introduce him.
No, sir, you can introduce Sir Subhash if you want. Subhash is joining, sir, is here.
He is joined. कुछ सामान Yes, Dr. Hafizur Rahman.
Yes, sir. Shubhas, are you there? Yes.
But
Subhas,
the audio is not connected yet.
Okay.
Subhas is senior consultant at Baby Memorial Hospital, Calicut, and he's the immediate past chairperson of FOGSI Endoscopy Committee.
Welcome, Dr. Subhash. Please unmute yourself and please let us know if you are ready because we are waiting for a long time.
Sir, I'm totally ready, sir. So I'm sorry for that, sir. My security okay, sir. I'm ready, sir.
Okay, so please continue with your presentation.
Thank you, sir. And sir, at the outset, sir, I would like to apologize for the sincere delay because of my flight got preponed. So now, I've find a topic per se that is about basics in hysteroscopy and what we would like to learn about hysteroscopy. It's about 20 minutes presentation where, as Dr. Hafiz sir and Dr. Ashok Kumar sir had said, we're keeping very basics as to the exam point of view with some clinical inputs. So that is the whole intention of the same. And now hysteroscopy, it means from the Greek term, which means that hystros means uterus and scopy means to look. Now, it is considered a real revolution of modern gynecology where actually we have a lot of things which we can understand. Now, there have been a lot of concepts between office hysteroscopy, outpatient hysteroscopy, ambulatory hysteroscopy, and many other things. The concept of performing the hysteroscopy, which is a new one, is without the anesthesia and cervical dilatation in an outpatient is the ambulatory hysteroscopy part of it. Of course, things have actually changed quite a lot. And currently, the thing that we see is the see and treat concept, which actually eliminates the risk of anesthesia, hospital stay, and makes them cost effective. But we'll stick on to the conventional hysteroscopy for the details now. Now, before we go into the hysteroscopy per se, please understand that we have the hysteroscopes and the sheets. So we have the hysteroscopy, which is actually the older one, which is the ones which we normally use, which is called as the rigid hysteroscope. And the other one is called as the flexible hysteroscope. Okay. Flexible hysteroscopy is not used much in nowadays. We actually go for more for the rigid hysteroscopes. Now, in the rigid hysteroscope, please understand that we have, this one. Can you see over here that the scope is over here? There's a sheet over here. Now, the dimension ranges from 2 millimeter hysteroscope to 4 millimeters. We have actually had 2 millimeters, we have 2.9 millimeters, and we have 4 millimeters. 4 millimeters is the bigger one where you can see much better off, but at the same time, it requires a lot of dilatation also. So please understand when you put a scope alone, the diameter is quite big. So not just the scope, you have to put the sheath again. So as and when you use a bigger scope, actually more and more dilatation is required to do certain procedures. Okay. Now the length of every scope is actually standard. It's about 35 centimeters. And it's actually runs on a system called as lens system. And it's a cold illumination. But make no mistake of the cold illumination, because if you had touched the light, the scope or the cable onto the skin, it can burn actually. Okay. Now, this is how you can see. Now we have the rigid operative hysteroscope. What I spoke initially is the diagnostic one. And when you operative, can you see over here? There is a working sheet over here. Can you see there's a working sheet over here where you can put in your hysteroscopy, where you can put your scissors or a bias forceps. This is again one more. Can you see here? There's the outflow and the inflow part of it over here. I'll come down to that slightly later. We have the optical system, which are many things that we normally use. This is the Bertocci standard hysteroscope. Can you see over here? This is normally the 2.9 millimeter scope. This is the outflow. This is the outflow, and this is the inflow. The one which is closer to the body is always the inflow. And the one which is away from that is the outflow, because you want to remove all the dirt. Hence, this is the outflow. And this is the working sheet from where you put in your hysteroscopic scissors or your. The other one is the Bertocci integrated scope, where everything is integrated into one. The diameter is very small, which effectively means you do not require a dilatation to do this procedure. So it's basically an office procedure, which means kahin pe bhi kar sakte hai, kabhi bhi kar sakte hai, but you don't require any anesthesia for the same. Please understand, it's the same concept which is used when you use a uterine sound or when you put an LNG IUS, because the normal diameter of the cervix is about 4 millimeters or less than 4 millimeters. Hence, there is no dilatation which is required for the same. The other one is the Versa scope, not in much use now. And the other one is the Campo, the famous guy from Belgium, Rudy Campo, who devised this. It's called a, this is just for your knowledge that we have other optical systems also. Now, the field of vision, please understand, you have 0 degree, where you see straight. Then we have 12 degree, which is forward oblique. And there's one more, which is actually 25, 30 degree scope. And the light source, please understand, since it's a 30 degree scope, it's always on the opposite side, which means that if your light source is coming from the top, you're seeing the posterior side. And if you're seeing from the posterior side, it's actually the anterior wall, the opposite side of it. Flexible, just for the sake of understanding, it wouldn't be asked much in exams. We have this flexible hysteroscope, which we normally don't. It's like a flexible bronchoscope sort of a thing. The camera system over here, you can see the light source, the camera system, all things. This is standard as we would do in a laparoscopy also. Now, unlike in laparoscopy where we distend it within a carbon dioxide and distend the abdomen and see it, here it's not a it's a very rigid organ. Uterus is a very rigid, unlike a bladder, where you need something for the distension to occur. Now we have the simple diagnostic sheet as I showed you somewhere over here. It is the inflow and the operative where we have the inflow and the outflow part of it. When you're doing operative systems, we would require the inflow and the outflow because you would require the fluid also to come out. Now to distend it. Now to distend the uterus, because it's a muscular organ, you would require some sort of, fluid pressure also for that to be maintained. Now, we have this gravity pull. Matlab jo upar rakhte hai na? So normally we'll keep a normal saline 1 liter or something and then we'll actually go on pushing it. That's the gravity. But gravity usually doesn't work out because you cannot have a control over the pressure. When you increase the pressure, you have its problems also. But when you decrease the pressure, that is also a problem. Then we have the pressure bag over here. Can you see over here? It's actually a combined one, but it has got its own pitfalls. This is the best, actually, the Hysteromat, which actually contains your inflow and contains your outflow also. This is what is the best part about the inflow and outflow. This is the fluid managing system, but please understand it has to be at least 1 meter above the heart level, for the pressure to be good. But it is only for your normal diagnostic ones. For operative, it is not much useful. Okay, this is called the hanging back system. Now, very, very important for us to understand, because when you put in an inflow, there will also be an outflow. But the amount of fluid which goes in and comes out is very, very important. Okay. Now, you should have somebody, some assistant actually who would look after only for this actually. So he or she has to measure the input and outflow continuously and keep the surgeon informed about it. Because when you have overflow, something like congestive cardiac failure, similar to that, you'll have an heart failure, congestive heart failure. So to be very, very careful about that, and you have to have an idea about what is the fluid deficit. Preparation of the patient, it's always better if you can do an HSG prior in case if you're looking for an infertility. Otherwise, it's okay. At the same time, nowadays, with a sonosalpingography also, it's much better. You can avoid an hysteroscope in case if you want to do a less invasive procedure. Okay. Timing, it's very, very important. We do not do it when we have a menstrual cycle. It's always under the post-menstrual cycle. And if you're expecting a dilatation to be difficult, you can always use a misoprostol. I, for one, am not a big fan of using a misoprostol because it becomes too soft and the chance of perforation are slightly higher. So hence, I would not say that don't use a misoprostol. My contention over here is that it could actually cause some sort of issue over here. So you can keep it 1 to 2 hours prior to the procedure. And the pumps which I showed you, the controlled pump, this is the most ideal wala and not the push, which we normally use for a dilatation. Okay. So you can always understand the inflow is always about 120 and the outflow you keep it at 50. But if you keep your outflow channel always open, you lose your pressure. So it has to be somewhere in between. So where your inflow is also good, the outflow is good for the dirt to come out so that your vision is good enough. This is a simple one. This is actually the ideal one, called as a hysteroscopy pump, where you have a very good idea about how you can see the outflow. Can you see here? the outflow, you have a management of how much is the inflow and outflow, so you can keep a track of it. Now, ancillary instruments. Now, we have used a scope, we have had a dilatation, now we have to use an instrument. Now, these are the instruments that we normally use. You can see this is a scissor, which is one side. This is a scissor which opens on both the sides. This is actually a grasper over here. Okay. Now, it's all semi-rigid instruments because it has to pass through the 5 French one. So it's a semi-rigid. It's not very hard. It's a semi-rigid one. And you have this graspers, you have scissors, and you have this punch biopsy forceps also in such cases. Okay. Now, rigid one, and you can see you have the scissors and the biopsy forceps. It's a sturdier one. It's a sturdier one, basically used for a larger. When you have a big septum, which is a thick septum, use these instruments for the same. Timing, as I said, post-menstrual proliferative is the best. No need of any special preparations or anaphylaxis will not required. But in case the patient is very anxious, you can always give an anxiolytics also. Distension media, I did speak about it in little. Now for what? Now it's a virtual space with walls which are closely opposed. It's a muscular one. Hence your distension is slightly more than what you would do a cystoscopy. And you need a good panoramic vision for the same. And the minimal pressure which is required is about 40 millimeters. Without minimum 40, you will not get a distension. At the same time, you have excessive distension, that's again a problem. The choice of distension medium is actually depending on your clinical setting, but it's an operative, or it's an outpatient one or in the theater, whether it's for diagnostic one or an operative one, and whether using an electrosurgery. If you're using a monopolar, you would require glycine or some other thing, whereas for a bipolar, you would use a saline. So you have to have an idea कि कौन सा इस्तेमाल करना है इसमें. Now, there are certain things which are ideal in life, which is not very easily. But again, in ideal, his distension medium should be isotonic, non-hemolytic, non-toxic, non-allergic, rapidly cleared, and good visualization. And unfortunately, we don't have something called as an ideal distension medium. So we do some sort of adjustments usually, It's not possible to use it. The same intrauterine pressure, as I said, is 40. And you have. But always try to keep your pressure lower than the mean arterial pressure. It's about 100. Because when your distension increases, your absorption also increases into the body. And when your absorption increases, your chance of having a failure or over distension is actually a problem for the same. Now, distension media, please understand this. We have the gaseous one, which is just for the sake of postgraduates to understand. Kabhi-kabhi hum istemal kar lete the, abhi kuch nahi karte. We don't use this. Okay. And there is a liquid one. Liquid, you have the highly viscous one and the low viscous one. We don't use the high viscous one now. We only use the low viscous one. And in the low viscous, we have one with the electrolyte, one without the electrolyte. So basically, one with the electrolyte is one which you use for your monopolar. Without the electrolyte is what we use for your saline. Now, distension media, similar one. Low viscous one are what we normally use, the dextran and everything. But electrolyte-free solutions, glycine or sorbitol is what we normally use when we use the monopolar surgery. For the bipolar, we don't require it. We actually go in with the normal saline for the same. Now, factors which are affecting the intravasation are intrauterine pressure. Matlab, if you increase the pressure, more absorption would occur. If your surgery is for a prolonged amount of time, then that is a bad thing, which means that you will have a problem in increased absorption, hence your complications would increase. Area of surgery. If you're doing a resection for a large period, more amount of absorption can occur, which is not a good thing. Okay. Flow of the fluid, as I said, inflow is about 100, outflow is about 20. Electric circuit, just one paragraph about that. Same like in a monopolar, when you have an active electrode, you also have a neutral electrode to take back the current in a monopolar. Bipolar, there is no issues. You can see both the ends over here. And the current is produced in both the ends. Hence, it is not a problem over there. Okay. The advantage of the bipolar is it's over a limited area. The current flow is over a limited area. So it requires less voltage. So complicated will be less. But use of bipolar with 0.9% is not associated with, saline. The better is that we don't have problems of, electrolyte one, like hyponatremia, hypoosmolality, we don't require. There's not much of problems with this. Isotonic saline is normally easily available in all the theaters. It's a low cost one. But more important is, it gives you an extra advantage. That your fluid extravasation is very, very less than this. So, thoda breathing space na thoda badhta hai isme. Matlab, even if you are erring on the wrong side, it gives you a slightly better chance, that you can err on it. It doesn't mean that you have to go on the wrong side, but it conducts electricity. Hence, it cannot be used in a monopolar. Okay, but it mixes with the blood and obscure the visibility. That is a problem. Glycine is the one which we normally use when you have an electrosurgery like a monopolar one. It's 1.5% glycine, which is important. Please understand, since it's a hypotonic solution, it actually causes a hypoosmolar. So there are a lot of problems that are associated. Like you could have your hyponatremia, your fluid absorption is higher in the intravascular space and the extravascular space. It will conduct, not conduct electricity. That is the advantage with the thing. But it gives you with a lesser margin of extravasation. So even at a smaller ones, you can have a problem with the patient. That is a problem. But the biggest problem is you can have hypotonic, you can have hypovolemia, you can have your pulmonary edema, you can have the brain edema and the ammonia, hyperammonia also. But there are certain factors which are bad over here, are good over here. If you can use a GnRH agonist prior to the surgery on a submucous fibroid, your volume reduces, hence that the problems are very less. If you give an intracervical vasopressin, of course, with all the safety of vasopressin, it would actually decrease your bleeding also and keep the pressure very less. Now, there is always a dictum which I always tell my postgraduates and residents that if you're seeing in an hysteroscopy, you're seeing everything pretty well, that means your pressures are very high. So थोड़ा अगर कम दिखता है तो भी चलेगा, but your margin is actually high. If seeing everything perfect, it's not a good deal at all. Okay. And outflow section, you keep an outflow section a good margin, it's always safe for you. Okay. Now, when you use a fluid, there are areas from which it can extravase. I've been telling that, fluid absorption. Can you see over here? It can go through the femoral end. It can go through your surgical aspect. It can actually be lost over at the internal os level itself, external os level itself. And the third one is there can be absorption into the body. So please understand these are the potential sources where your fluid will be lost or can be lost. Fluid deficit, as I've been trying to scare you for the last 5 to 7 minutes, it's very important for you to understand what will be the fluid deficit. Please keep this, this is a rule of thumb, okay, where in a normal patient, up to 1,500 ml of your fluid deficit is acceptable in a normal cardiovascular patient. But as and when the age increases, the patient has had some cardiac problem, it would decrease to about 750 ml, which means that beyond 750 ml in an old lady is not a safe margin. Whereas a normal human being, up to 1 to 1.5 liters is a good margin. Beyond that is your problems which can occur. Now, indications of hysteroscopy, now that we have learned what are the problems, indications, as you know, for abnormal uterine bleeding, for the perimenopausal ladies, for infertility, pre-ERT, IVF failure, in additions, intrauterine additions, for foreign body removal, for misplaced IUCDs, and again, endometrial biopsies, it is actually useful. Now, let's go to the practical aspect over here. This is how we normally introduce the hysteroscope. Okay, this is actually a unedited video. Can you see over here, there's a margin over it. Here, I'm actually turning the cord. As I told you, if your cord is on the top, you are seeing the posterior. Can you see this is the posterior fornix which is seen over here? Please understand you're seeing the posterior fornix. And this is the os, the external os. This is a no-touch technique where I'm going in. You can see the cord is over here. Can you see the cord? Which means we are seeing the left lateral wall of the patient now. And it's on the right side, it's the left lateral wall of the uterine wall. Okay. Slowly you enter and just pause forward. It's the same thing again. You can see the crypts. You can see the Nabothian glands, if at all it's over there. Okay. You can see slowly the Bartholin's if it's there over here. Slowly enter. Now, the dictum in hysteroscopy is always try to stay in the center of the screen. If you go to anteriorly, you may perforate. If you go posteriorly, you may perforate. So always stay in the center of the screen. So you can see here. Now they have to enter. Keep it in the center. The cord is down. Can you see the cord is down? I'm seeing the anterior wall. Now I've put the cord to the left. I'm seeing the right tubal ostia. Can you see this? The right tubal ostia. But everything is ulta bulta. If I'm seeing the opposite side, now I'm seeing the here, I can see the left ostia, the right ostia. Now I'm seeing the posterior wall, it's anterior. Okay. When I'm coming out, I'm again coming out. So please understand that's how it normally do. So nowadays this is called as a vaginoscopy technique where we don't use the valcellum, we don't do the cervix, we directly go inside. Okay. Now again, this is a similar one over here. Now please understand a similar one. See, careful, this is actually slightly bigger video again here. You can see the anterior fornix, this is the posterior fornix, the lateral fornix. Because in the case of infertility, you may get some subtle points. You can see the Nabothian glands over here, the crypts over here. I'm entering the cavity over here. Okay. Slowly, you can see that the negotiation of the internal os is the most difficult aspect. It is very, very difficult. If you can able to negotiate the internal os, your surgery is half done. So that is why you have a lot of patients in hysteroscopy, as we keep saying. If you are lost always come back. Don't be aggressive in the moment. Dikh nahi raha hai, always come back. Don't be very, very dogmatic, Come back slowly, see, you can see how well we are inside. So when you don't understand always in hysteroscopy, always try to come back, have an assessment again. What the mind doesn't know, the eyes can't see. But I believe that hysteroscopy can see everything inside the cavity. Okay, now troubleshooting. As I said, we have in areas where you can have this fluid loss. If there is a leakage at the cervical level, you can use this. It's called as a glimpsis stenoculum, which would actually approximate the external loss so that there's no fluid loss at this. Okay, outflow suction. If it's open, please close the outflow suction because if your outflow suction is always on, then your pressure actually decreases. So that is one. Transtubal loss can be decreased by your lesser pressure. Intravasation also can be decreased with your lesser pressure. Now, distension. If you don't have a good distension, please understand, think of the common things first. Don't think of perforation per se. There could be a leakage of the cervix. There could be equipment leakage where there is a leakage from the internal tube. It could be tube because they're all silicone tube if it's bent. If it is bent, your fluid doesn't come forward. If there is an excessive outflow, your fluid is lost out, so you may not have a good distension. If there's an obstruction of the stopcock, when you move these alleys, there is an output and there's a closure. Now, this closure, if it gets inadvertently closed, you would have a problem of the same. And there could be significant intravasation also. Last but not the least, think in terms of, perforation. Okay. If you don't have a loss of vision, if you don't have a good vision, the reason could be that there's a blood secretion at the edge. You just press against the fundus. Scope ko jaake fundus touch kijiye, wo jo blood वगैरह hai, ja jayega. So you can be having a good vision. If you're having some fluctuations, always close the outer wall. That is the outflow wall, so you can have a good vision over the same. And allow the debris or the blood to outflow over here. Now, again, over here, please understand over here. This is very, very wrong. This is the os, and I've gone by mistake. I've gone over here. Can you see this? This is wrong. Now, how you would know that you are wrong is because you can see the white fibers over there, the white fibers over here. Whereas when you go in the right plane, you will not get the fibers, rather you'll get the pinkish ones. Okay, this was the wrong method over here. What I have done is wrong. I've gone into the false passage, which is very, very common. Okay, so don't do this because we don't want to be, hi Bhagwan, hi Daya, not should be the case. Hemorrhage. And you're using for a surgery, there is a lot of bleeding. You may have to abandon the procedure. And post this, you will have to put a Foley's catheter, a bigger Foley's, not the normal one. You may be a 21, 20, number 18, three-way also you can use so that you can put a Foley's and there can be a distension also. But please remember that the catheter should be left for a few hours and they have to always put a good amount of antibiotic coverage and painkiller. Because whenever there is something which is distending the cavity, you will have a lot of pain in the same. Okay, if a lot of bleeding, the way to come out of it is you irrigate, you aspirate, you let out the bleeding. Okay, this is a similar one. Now, just a couple of lines about bipolar receptoscope and mini receptor, where you use the same for your submucous fibroid, when you resect it across. Okay, if you have an air bubble at the front of hysteroscope, just turn the cord and you will lose the air bubble because when you have an air bubble right in front, you would not be able to see that. Okay, now, when you have an intraoperative loss of visibility, which means that not the suction, dikhi nahi raha hai, so please check for the irrigation system. Probably if the irrigation system is switch off or there's no fluid, that is why there is no distension. Check for the outflow again. Find that the outflow is too much, you may lose it. Again, leakage from the os, but of course, as I said, perforation should be a last option. Now, please understand, this is a very nice. This is a very nice. Can you see over here? You can see over. I have a lot of patients in seeing for the same. You can see the fundus of the uterus over here. Check for the. Can you see the ostia over here? Yes, you can turn it across. You can see the ostia, the opposite side again, and come back. This is actually you're doing a surgery in the immediate post phase, and that is why it's so reddish. This is in a postmenopausal lady. You can see it's a very dry one. It's very, very dry. You can see there is much of polypoidal lesions over here. Okay, it's a very bald endometrium. This is just for you to understand the difference between a menstrual lady and a postmenopausal. A premenopausal lady and a postmenopausal lady, just for you to understand how it would look like, Right. Now a polypoidal lesion, you can see over here. Here, I would be using the grasper, I'll be using the grasper over here. Go inside. Okay, go inside. You can see here, it's a multiple jaw. Okay, hold it, pluck it out, and take it out for a biopsy over here. If you're suspecting a very, very obvious lesion somewhere, it will be good for you to go directly to the lesion and take the biopsy for the same. Okay. Now septum over here. This is actually a Collins lab, which is actually a monopolar one. Can you see there's a monopolar one over here? So please understand, you are using a monopolar, which means that you will have to use a glycine. Okay, you cannot use the same with a saline, you'll have to use a glycine for the same. Okay, now you come back, you've seen the both ends of the septum. Okay, and just come back. Okay, I've seen the ostia. This is for you to understand the depth. Pehle you'll have to gauge out kitna jana hai, kitna nahi jana hai. And the trick here is always stay in the center. If you're posterior, ye dekhiye, this is a septum and I'm trying to go in the center of the septum. Okay, can you see this? This is septum going slowly, transverse, transverse, transverse. It may not be very prudent, but the dictum is whatever is white is mine and whatever is red is belonging to the patient. So you can see white fibers, the moment you see the white fibers, you don't have to worry over here. And if you see what I'm doing, after every cut, I'm coming back and I'm assessing. Yeah? Don't feel anything कि मुझे सब आता है, मैं सब करूँगा, नहीं. Always, once you see, you come back. Because you have to have an idea कि कितना जाना है, कितना नहीं जाना है. As and when you see, the fluid pressure will actually oppose with what the wall which is opposed is, it will go away from that. And that will help you out very nicely. Can you see this? The wall itself is moving away. That is nice. And here you can see here. The moment I would see white, I'm okay. I'm actually assessing kitna dur hu main. Can you see these pink fibers over here? Okay. When you see the pink fibers, stop. Okay. You see the pink fibers, you stop. You can see over here how well the cavity has been distended. Septum is taken care of. But please understand, agar thoda bahut, chota sa subseptum ya septum, agar you leave it back, nothing is going to happen. So in order to be, don't have to be too over-aggressive. Because in your over-aggressiveness, you may actually perforate one. So don't do this. Okay. A submucous fibroid, the types, I would not go into the depth of it. Type 0 and type 1 is what I will be, very comfortable in doing. Type 2, you have to be really good in doing it, which is more than 50% of inside the cavity. Okay. Now, a similar one, you can see here, if it's a bigger one over here, I can see over here. Can you see a submucous fibroid? It's actually a type 0. So it's okay with me. I can do it pretty well over here. Okay. Now, for you to understand, that's how the knife is. This is submucous fibroid. On the top, what you're seeing, I am using the monopolar. Can you see this monopolar over here? I'm assessing and I'm cutting. Please understand, whenever you have a peduncle, don't go and cut the peduncle because it will just go rotating over there. So small piece, small piece. And always the dictum is, you start from the distal and come down to the proximal. You don't go from proximal to distal because you don't want to perforate the same. Okay. Similar one, you can see over here. Slowly. Again, for the page, for the understanding, it is a monopolar. So the fluid which I'm using is glycine. The second one over here is seen pretty well. This is actually a normal saline. You can see this is actually on the opposite wall. Same dictum again. I go from the proximal end to the distal end. I go from the proximal end to the distal end. Okay, please understand it. I'm going from the proximal end. I'm sorry. I'm going from the distal end to the proximal. I got a phone call. I'm sorry for that. Okay, that's what. Now, perforation may be done with a cervical dilator or with a hysteroscope, but you should always have an idea to see to that when you have a perforation, that when you're using a current, whether you've gone and touched things. Now, see here, this is the unfortunate part of the perforation over here. Can you see this? Can you see this? This is actually the intestine. You can see the appendix epicloica here. And this is very, very dangerous because you used a current. If you use a current over here, you have to go and see whether you have damaged the appendix. Okay. But please understand, whenever there is a new one, a newer technique comes, we are always against it. But please understand, be not afraid of growing slowly. Be afraid of only standing still. Hysteroscopy is a part and parcel of our lives. We have to utilize hysteroscopy in our life. There is no way we can go around. But you have certain challenges and averting the complications is important. You have to understand what are the procedure, what is the procedure, and what are the problems which I may encounter. That is very important. Second is when we enter the cavity, as I said, you have entered the interlos cavity, that's it. Your half of the surgery is done because that is where the problem arises. Intraoperative challenges, know your problems and know how to come out of the same. It's very, very important. The last is the post-operative. Post-operative complications is also very, very important for us to understand. Proper patient selection and counseling is very, very important. Not for every case. Understand the disease, understand the physiology, you understand the pathology. If you understand the pathology, then you understand the pharmacology and the gynecology, and that will be easy for you. Okay, know your instruments thoroughly. Have a good idea of the instruments, what is useful, what is not useful. And of course, as I keep saying always, please attend these trainings by FOGSI or ICOG, which will help you out, which is a key to success. Textbooks will help you, YouTube will help you, but no, there is nothing like, from the horse's mouth. That is why I keep saying, training by ICOG or FOGSI for that matter, please do understand, attend this. This will be really, really helpful for you. Now, this is something which is controversial, which I would always say. Does hysteroscopic surgery spell the end of general gynecs? No, my dear friends, I'm not here to say that hysteroscopy would spell. General gynecology, your good old DNCs, the good old fractional curettage still hold good, but of course, hysteroscopy is an added armamentarium to which will always be helpful. Now, the only difference I will make you understand about hysteroscopy versus a normal DNC would be, when you do DNC, things would be something like this, which is, you know what it is, but there's not a lot of clarity in this. This is how a DNC would look like. But if you use an hysteroscopy, things will be much, much, much clearer. This is something which I would like to make you understand the importance of hysteroscopy for the same. Ladies and gentlemen, thank you very much. And I would sincerely apologize for the delay, because I was in the airport and my flight got delayed. I'm sorry for that. And sincerely sorry to Dr. Ashok Kumar sir and Dr. Hafizur sir that I got a bit delayed. Archana madam, thank you very much for filling me at the right time. I'm actually grateful to you also for the same, ma'am. Thank you, ma'am. Thank you very much.
Dr. Subhash, thank you very much. Your presentation has really filled the gap, and there's no need to say sorry for all these things. These happens, and but we have to be careful that our students should not be kept on waiting. So thank you very much, and your presentation was good, and really what we wanted, that the students should learn from hysteroscopy, and it is a very important question nowadays in the exam also. So if there are any queries in the chat box or anything, can you please share the host who is there? If there is something in the chat box, you can share with us.
Yes, sir.
Subhas, that was a wonderful presentation for the PGs and UGs.
Thank you, ma'am. Thank you, ma'am. Thank you.
All the basics you covered, and as Ashok sir also said, they do have this hysteroscopic instrument during table viva.
Yeah, Dr. Subhash,
what happens if you use normal saline with Collins knife? See, when you use a normal saline with Collins knife, this is an electrolyte bridge. So what happens? You can get the current will flow. You can have the cautery injury. It can cause a cautery burn, because you never know which is the point of exit. So that is why it is a very, very difficult thing. You should not use, because it conducts electricity. Hence, please don't use it, because, as I said, as with a cautery burn, it is similar to a cautery injury. Hence, you cannot be using the same.
Is there anything else?
Yeah, technical persons, I would like to know the name and email ID and phone number of the winners of the quiz for today.
Okay,
Yes,
ma'am. I will share.
That will be shared, madam.
Yeah, please share with me or in the group.
Okay, ma'am. I will share in a group, ma'am.
Yeah, please.
Okay.
Today only, please do that, no? So that I don't forget.
So,
Yes, ma'am.
if they are, Dr. Hafiz Rahman, you want to say something?
Subhas, you are in the airport or you reached home?
Okay. So,
Airport, madam.
Acha,
okay.
Kolkata.
So, thank you very much. We close this program now. And I thank all our speakers, expert teachers, students, and all our staff from ICOG and all our office bearers of FOGSI and ICOG. Thank you very much for this very informative Sunday. We have got so many new information, and we have discussed the management of hyperglycemia. Then before that, we have our pelvis and skull demonstration, and then Dr. Subhash has given us insight into the hysteroscopy, and we had the quiz also on hyperglycemia. So thank you all, and we will meet you on the next month, second Sunday at 11:30. Till then, goodbye, and best wishes for all your teaching and learning. Thank you, madam. Thank you all. Thank you, sir.
Bye.
Yeah, thank you so much, everyone. So from here, I'm ending this meeting. Thank you.